Welcome to another day of the webinar. My name is Carrie Ann, and I'm the nurse educator coordinating general orientation. And it was a privilege to meet some of you yesterday, the Allied team yesterday for their safe patient handling. Thank you for coming in. Let's start our day with land acknowledgement. We would like to acknowledge that we are gathered today in the traditional and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh people. Just a reminder that we are in Zoom for the day, so please keep yourself on mute and please be on time. Come prepared for questions and come prepared for answering the presenters. If the presenters have some questions as well, please be respectful. And also, we would appreciate to have your name for first and last name written on the participant list, not on the chat, but on the participant list on the Zoom, just so we will be able to mark you down for your attendance. And that's how you'll get paid for attending the session. Thank you. We're also going to use Slido this morning. So we're going to use Slido to interact with our facilitators during the orientation. So this is the event code would be GoPHC. And we're going to try that. So let's try that. So I'm going to let you go to GoPHC and Slido.com, GoPHC. And we have a Slido question that we're gonna show. So the question is, who do you think are your resources at work? Let me okay. There. Who do you think are your resources at work? Your PCC, patient care coordinator, CNE, your colleagues, yes, your manager. CNE stands for clinical nurse educator. Your educators, your colleagues, your intranet, yes, HR, yes, managers, fellow teammates, and the ward, all of the above, thank you. Yes, so those are good answers, thank you. I'm gonna go back, there you go. So as you've mentioned on the list, so you have your, we call them CNL, so clinical nurse leaders. Some health authority call them PCC, patient care coordinator. So clinical nurse leaders are the one who manages the operations of their ward. So the in and out, the bed it's a bed management for their area. Versus when you see at the bottom, there's also a clinical site coordinator who mans, clinical site coordinator here mans the whole hospital, the in and out bed management for the hospital. You also have your clinical nurse educator. So after this week, you will be with your clinical nurse educator for your unit orientation. Also your patient care manager, which is your hiring manager. We also have our allied team, dietitians, physio, OT, social work, music therapists. They're all part of they are all good resources. Our security is a good resources. And somebody mentioned the intranet. So in the intranet, we have SHOP, which is the Shared Health Organization Portal. Technically, SHOP, you could access SHOP from home. So you can do it through Google Chrome. You have to type in the whole, the name. You have to type in Shared Health Organization Portal. You can't just type SHOP. It's going to get you to shopping stuff. But if you write Shared Health Organization Portal, you'll get the SHOP. You have Lexicom. You have your PDTM, so Parenteral Drug Therapy Manual. Our IV therapy is a good resource too. Wound care team, palliative care outreach team. We also have AMCT, addiction medicine consult team. they have a liaison nurse for that one, and also CCOT, so Critical Care Outreach Team. And the most importantly, one of our greatest resources is our colleagues, especially when we're new. We bounce on each other for ideas and questions. So your colleague, your buddy nurse, your buddy, the person who's with you during your orientation shifts is a great resource. I just want to touch base quickly on security. So here at Providence, security's main role is to support the clinical staff in the safe delivery of clinical care. They are also the first aid attendant on site, and they can be reached at non-urgent and urgent. So non-urgent is 477. And then when it's urgent, when it's emergency, when it's code white, dial the code button, which is 7111. Security works under the clinical direction, and they cannot be left alone with the patient. So when we call for code white, we need to be there. We need to brief the security of the plan, what's the issue, and also what if there's any precaution. They would appreciate that one. We're working as a team. The security also have a safe walk program. So if you do not feel safe walking to your car or for transit, you can call security to walk with you within the footprints of the site. So within the grounds of the hospital, they could walk with you. They also have a suspicious person activity. So if a suspicious person or persons are seen, please alert security as quickly as possible and provide an accurate description of the person of interest. And the security can remove anyone as directed by clinical staff, or if the person of interest does not provide a valid reason for being on site. So that's security is there for us. Just a reminder, for BC emergency codes, we call 7111. These are the codes that we have, and we're adding the code silver, which is active attacker. And for the nursing colleagues, there's also the Acute Nursing Practice Council. So this group meets once a month for 2 hours, and pretty much they will it's a collective thinking. So any changes, any issues within the organization, they will talk about it in there, and they would also promote knowledge translation challenges and practice based on research. So if you want to be part of the Nursing Practice Council, just send GoPHC an email, and we're happy to connect you to the team. And you're paid to attend. When you attend the meeting, your hours are paid. Albert Einstein mentioned, I have no special talent. I am passionately curious. So when you get to your units, just put on your curiosity hat. And remember, we're all here for each other, and we're all here for our patients. Thank you. Okay, everybody. Our next topic is managing unsettled behavior. And here with me is Talina Hale. She's the clinical nurse leader in our emergency room here at St. Paul's, and she's going to tell us more about this.
Thank you, Carrie Ann. Hi, good morning, everybody. The educator for the emergency department, Francis Tenario, is not with us today, so I'll be doing this presentation, his part, together now. Okay. So we're going to talk about managing unsettled behaviors, and in today's session, we're going to talk about patients that are admitted under the Mental Health Act, voluntary patients with unsettled behavior, and a least restraint approach, as well as using chemical and physical restraints when managing patients with unsettled behavior. Okay. So firstly, I would like to talk to you just regarding why I'm going to be talking to you about patients underneath the Mental Health Act that are detained and getting treated in hospital. And what this is in 2019, there was a ombudsman's report called Committed to Change. And this was released to the health authorities and the government. And what it highlighted was in June of 2017, there was an audit. And what it showed is that it was highlighting the lack of compliance with the legal documentations required for individuals that were detained underneath the Mental Health Act in psychiatric facilities throughout the province. And this should be 100% of the time, all of these forms and rights should be given to patients, but at the time, it was only 28%. So the report really highlighted that we need to do better and we need to make some changes. So the 24 recommendations were accepted by the government and the health authorities. So part of this session today is talking to you about the Mental Health Act and just the legal requirements within that. And why this isn't just mental health areas in the past or psychiatric facilities is because all staff that work with patients, these are providers, social workers, bedside nurses, that work with patients that are admitted underneath the Mental Health Act need to have training and understand the requirements that need to be completed. So the Mental Health Act allows us to admit and treat people with serious mental health issues who are at risk of themselves or others. And to be certified or detained underneath the Mental Health Act, there's 4 criteria that needs to be met. And the first one is that the individual has a mental disorder that impairs their ability to interact with and associate with others appropriate in their environment, that they require psychiatric treatment in or through a designated facility, as well as care and supervision to protect themselves or others. As well, this is the biggest part, is the patient cannot be admitted as a voluntary patient. So how does that work with the Mental Health Act? So the first, it's called a Form 4 or a medical certificate. And this medical certificate, if it's completed by a physician that meets that 4 criteria that I just described, that one Form 4 is valid for up to 48 hours. A second Form 4 needs to be completed by a different physician within that 48-hour period. And if the patient still requires or meets the criteria that for being involuntary admitted, then the second certificate will be completed and the individual could be certified or detained in hospital up to 1 month. And then as the Mental Health Act goes on, you can renew that first Form 4 by a Form 6, and that's good for 1 month, 3 months, 6 months, and ongoing. And when we talk about someone being admitted to hospital and detained under the Mental Health Act, these are the criteria that need to be, also the forms that need to be completed. And the first one is a Form 5, is a patient consent. So because the individual is not an involuntary patient from that first criteria, to provide treatment underneath the Mental Health Act, a Form 5 needs to be completed by the physician and most often a clinical nurse leader or a designate from the designated facility. And in this case, from the emergency department, we have psychiatric assessment nurses. And in your inpatient areas, most often that's a clinical nurse leader. Or in medicine, we do have support from the consult liaison psychiatry team, and they will perform this for you. So the person can be detained under the Mental Health Act, but in order to receive treatment, for example, medications, this Form 5 needs to be completed. The form Patient's Rights is called a Form 13. So this is done and completed by anybody. Really, it could be the clinical nurse leader, it could be your bedside nurse, it could be a physician. But a Form 13 is a notification of rights for the individual. And they have the right to know, for example, where they are, why they're being treated. And they can also apply for a review panel, which is called a Form 7. Next is the notification and nomination of near relative. So an individual can choose who they want to be notified that they're admitted to hospital involuntarily. This is done by most often the social worker on your areas. And also if there is no nomination of near relative, then the public trustee gets this notification. And these forms all have to be completed within 24 hours of detainment underneath that Mental Health Act. I'm just going to add, there's Karina Campbell is the Mental Health Act educator for St. Paul's Hospital or Providence Healthcare. So there is someone that you can ask or get provided more education and details on this.
Oh my God.
And then this is someone's admitted to hospital and they are continuing to meet the criteria to be detained under the Mental Health Act, but they don't need acute hospitalization anymore. They can be discharged from hospital, and that's on a Form 20, and that's like a leave, an authorization of leave outside of the hospital. So this could mean that the individual is has the kind of signs a contract, like is expected to take their antipsychotic medication, for example. They're to follow up with their mental health team, and they have somebody in the community that is looking out for them. So they're discharged from hospital on this leave, and then if they fail to comply with these expectations of the leave, they can be returned to hospital under a director's warrant or a Form 21. And I'll talk about that in this workflow here. So just kind of an overview, a person could present to the emergency department with mental health concerns. They then are assessed by the physician. Let's say the individual presents with depression or feeling anxious. They're seen by the emergency physician. They're agreeable to be there. They understand what they're experiencing. They are, not acutely suicidal at the moment. So they're seemed to be assessed and deemed to be voluntary, not meeting that criteria for certification. And then they just continue on their treatment, whether admitted to hospital, discharged with community supports, however that may go. The other way that somebody could come in is that same person, and then the physician sees them and has an assessment by them and finds that they are acutely at risk, say of mental health and deterioration, that they maybe are acutely suicidal. At that time, the individual could be certified under the Mental Health Act. They meet that criteria. And then therefore, the emergency physician will complete the medical certificate through Cerner, and that's electronically signed as a Form 4. Immediately then, before any medication is provided or treatment is given, the Form 5 is completed by the psychiatric assessment nurse here or the clinical nurse leader. The bedside nurse will complete that Form 13 of the patient rights, and then the Form 15, 16 is completed by the emergency social worker. Another way people could come into the hospital, individuals, is they present in the community from presenting in a manner that the police believe that this person has a mental disorder and needs to be assessed by a physician. So they could come into hospital under Section 28 of the Mental Health Act. And then their same process assessed by the physician, either voluntary or involuntary criteria. And then, or based on the previous slide is of the Form 21, where someone that has failed to comply with their Form 20 extended leave, authorization of leave, they can be recalled on a Form 21. And then everything else on the far right here, the Form 5, 13, 15, 16 needs to be completed within 24 hours of admission. So why are we talking to all of you, besides just mental health areas, about the form completion and who's responsible for doing this? It's because that, like I said earlier, we're only at 28% compliance in the province when the ombudsperson did this report. And this needs to be completed 100% of the time. It's very significant that people have an opportunity to have their rights shared with them and that they have someone to advocate on their behalf. And in medicine, you could have an individual that presented to the emergency department, say with an overdose, like a polypharmacy overdose. They're then, say, acutely suicidal. They become certified and they become admitted to medicine and they're on your wards. All of this still needs to be completed versus just on mental health areas. Oops. So what is the special care, or if there's any consideration to care for somebody that is underneath the Mental Health Act or in mental health areas, is first of all the environment. We want to make sure that if we talk about that individual that is acutely suicidal or is at risk of harming themselves, and at the moment they're unable to control those urges or those behaviors, we want to make sure that the environment is safe. We want to make sure that the bedside table maybe is free of things that could cause harm. We want to also make sure that you're aware of your code system and your code maybe white, or just like your code blue buttons, you want to make sure you have your code white buttons, which is a call for help. That could be an unsettled, aggressive patient, a violent patient, and it all could be, I just need help. So if you have areas that you wear personal protective devices, then they're called PPDs, then you have that on your person. If not, just be aware of where your code buttons are or how you call for help on your areas. We also have that to consider that people are on close observation. That's that we need to always be aware of where they are, what's their behavior, where are they located, make sure they haven't left the hospital. So people are on Q15-minute observations commonly. Patients that are admitted to hospital are also, according to risk, their belongings are removed. They're in hospital attire. That's to make sure that we don't know what's on their person. If they came in from a pass or from the outside into the emergency department, they may have something on their person that could cause harm to them. For example, they could be thinking about overdosing. If we talk about that suicidal patient, that they may have that on them. So we remove those risks. Security and nurse escort on all transfers. We have security to make sure that the individual is an elopement risk. Maybe they try to leave. So again, we assess the patient for our risk, and we take those considerations appropriately, or make those appropriate considerations with care of the patient. So that's a non-voluntary patient, but in most circumstances, all patients in hospital are voluntary. They're not certified under the Mental Health Act. They are considered, they're aware of their care, they're seeking treatment, they're in hospital to have that care done, and they've given consent. They also can have the right to revoke consent at any time. So when we talk about the health, I'm just going to briefly talk about the Healthcare Consent Facility Act. And just to make you aware of that is that there's 3 parts to this. First of all, the emergency it's an emergency to preserve the adult's life, prevent serious physical or mental harm, or alleviate severe pain. Well, what this means is the adults needs to be impaired or otherwise unable to give consent. So everything we do really is about consent, and that there isn't a substitute decision maker available to provide consent for this person. So healthcare may be provided without the patient's consent. And as I put this together, I'll say that for part A here is that someone could be intoxicated or unconscious, semi-unconscious for any reason. So they're unable to provide you with consent. They didn't maybe walk in, or maybe they did walk in and then their status changed immediately. We are going to perform life-saving events in order to preserve really their life and limb. So I guess what the big part is again, I'll just say, they do not have the ability to give consent, and we don't have somebody saying, don't do this care or do this care. But I'll put it together as an individual, perhaps has come into the emergency department unconscious, and they've come in, they were found, EHS was called by a bystander, they called 911, this person wasn't breathing, they didn't have a heartbeat, so they performed CPR. They brought back their heart rate, they brought back their circulation, they come into hospital. The individual wakes up and starts flailing and fighting and wants to like leave the hospital. But they've just had this massive event. At that moment of time, an individual, a nurse or doctor, can put the person in restraints to perform life-saving treatment. So this is only talking about putting an individual in restraints that's exhibiting an unsafe behavior while you're preserving life, and they're not certified. I know it's a bit heavy, but we just need to just share a little bit about why we can put people in restraints. The other part could be that an individual comes back to your ward from a pass and then they collapse. Again, you're going to run a code, you're going to do everything. Maybe you provide them, we'll say it's an overdose, maybe an opiate overdose, you provide them with Narcan, and now they're flailing and agitated and trying to leave again or fight. At that moment of time, if they're fluctuating in and out of consciousness, you could put the person in restraints to provide more treatment with them for that moment of time. But in order to do this, it's not just putting people in restraints and providing treatment. Because they're a voluntary patient, and you're doing this without their consent, which is a doctor needs to say that we're performing this treatment, and they have to receive another opinion of another physician as well to perform the treatment. So again, it's just about putting somebody briefly in restraints to perform that treatment under Section 12 of the Healthcare Consent Facility Act, or Section 14, which is here again, just knowing that there's an act that you're working on or within to provide care. And it's only when restraint will be considered as part of the patient's plan or care plan at this point. So, emergency treatment, if able, patient gives consent. If inability to consent for mental health reasons, that's the Mental Health Act, and that's a Form 4, medical certificate, or Form 5, consent to treatment. Inability to consent not for mental health reasons, this is Section 12 of the Healthcare Consent Facility Act. And if able, patient may consent or ongoing care, it's the temporary substitute decision maker that's required. And most often, this is ethics, team involvement under Section 14. So again, this isn't anything that's just like very black and white. There's a lot more in depth to this and care for people that you're treating for. And this is only in the context of the least restraint policy, so for restraints, applying restraints for the moment of time. So what are restraints? And in the definition here, restraints are devices, environments, or medications used to restrict a person's behavior, movement, or normal access to their own body. So that's a pretty strong statement. And restraints are only used when alternative interventions have been unsuccessful. These interventions are employed early, and if they are, sometimes restraints can be avoided. And if restraints are applied, it's in the least restrictive manner for the shortest duration of time. And when we apply restraints, we need to think about these are applying restraints are only for, to protect someone's safety, staff safety, patient safety, co-patient safety, residents. And we need to minimize the need for restraints at all time by providing de-escalation techniques if we can. We'll talk about that in a minute. But for restraints, these are on your shop policy. And I do, if you work in an area that you potentially will be using restraints, is to review this, managing unsettled behavior, least restraint approach, and know that there's limb restraints. Even if you work in, like, say, long-term care, or you maybe use things like mittens or something, or elbow immobilizer, which aren't commonly used in acute care settings, and also Pinel with a locking belt. At St. Paul's Hospital, we don't use the Pinel, we use the limb restraints, but just to be aware of the areas that you're working on. Anything that is not on this list is not approved. So an example is, I was working in long-term care a long time ago, and a woman was sliding out of her wheelchair, and at the time, someone suggested using a blanket to tie her to the wheelchair. Even though that intent is, I don't want this person to slide out of their chair and injure themselves, but that's not an appropriate, that is a restraint, and that's not an appropriate use of restraint. So de-escalation. De-escalation should be attempted on all patients at all times if they're experiencing a behavior emergency or behavior crisis. But do consider the presentation of potential harm to the patient and other co-patients and yourself and other staff at the time. So effective de-escalation techniques: chemical restraints, soft limb restraints, the hard limb restraints, secure room. The secure rooms are located on mental health areas, and these are lockable rooms that the individual is alone in a room, away from harm of others, and for assessment of risk of harm to themselves. And then limb restraints are, of course, on your ankles and wrists. The soft limb restraints are just restraints that are just on your wrists, and chemical restraints, and we'll go into that here. But I just want to say that this, from the top to the bottom here, isn't necessarily the route that you would go. Try to talk to your patient first, make sure that they're okay, and then provide them with PO medication, and then to continue to escalate, and they end up in restraints. That's like a perfect way, but sometimes an individual, you could come in and they're already in a behavior emergency, which is an escalating code white situation, and you may need to apply restraints first and then provide them with chemical restraints and go that other way. So it's not from top to bottom here. It could be you could start anywhere. So chemical restraints are used alone or with physical restraints, and these are only ordered by a physician. So it's Providence Healthcare or St. Paul's here. We use lorazepam and midazolam, and this is sedatives. Monitor for, of course, respiratory depression and any support that's needed. Loxapine, Haldol, and Zuclopentixyl acetate are antipsychotic medications. that are used, and we just note that Zuclopenthixyl Accuphase or acetate is not Zuclopenthixyl decanoate. Now, these two, we just talk about this briefly here because these two medications are, one is an intermediate working medication, the other one is a long-acting depot medication. So Accuphase, the one starred here, is on mechanism or onset of action is 12 hours and lasts up to 72 hours. So if you're giving this medication, which is primarily only in mental health areas, this individual should not be probably discharged after receiving this medication. And then the Zuclopenthixyl decanoate is every 2-week administered medication. So decanoate only comes from pharmacy, which is Zuclopenthixyl acetate is in sometimes on your Omnicells, and especially in mental health areas and in emergency. Of course, monitor for any dystonia. And then, so akathisia, tremors, and you can, there's benztropine and benzodiazepines are used to help support that if you notice that there's people are experiencing any dystonic reactions. So when applying physical restraints, there's two things that we recommend is that security must be considered when applying restraints and that chemical restraints should be administered. When we say that, we talk about the individual that's having a behavior emergency and you need to put them into restraints to prevent them from, injuring themselves or others. At that time, that's a code, white, and that security will be there, or you will call them and have security to help support you to be able to contain or control the individual at that moment of time. When we talk about when they can be considered, we talk about maybe think of a patient that you have that's admitted and they're maybe become delirious and they're attempting to pull out their IV site or like get out of bed, but they're unsteady on their feet and you're concerned about them. And you need to, but providing care, you need to be able to put them into restraints or to somehow keep them in their bed safe. And you're going to apply the soft limb restraints. You could do that by assessing your patient to do that with your colleague and working together. But any kind of situation where is an imminent risk of harm or danger to yourself or other patients, do call security and have them as well. Putting anybody in to secure room must have security presence, and I'll go over that in a minute. So this is how the bed play or an individual placed in restraints looks like. So somebody with severe agitation, like violent, like maybe agitated, threatening, thrashing about, at some point, this one arm up, one arm down is a very short-term placement of a patient that's actually not recommended by the company that makes the restraints because there is a risk of injury to a shoulder of this. So just be considerate of that. And I'll share between the two in 1 second. The second image here with two arms down and legs together, this is the preferred method. But if somebody, which I've experienced in the emergency department, for example, that somebody is very agitated and they're come in with police and they're in restraints at that time, and it's quite a distressing situation, and they are thrashing about, they could, with their head, two arms down, you can lift your body up, and people have tried to flip the stretchers over. So having one arm up will restrict that movement. But the person at this time is being monitored like one-to-one with nursing staff and providing medication. So you don't give, and then this is the two arms down, like we talk about that delirious patient that's going to fall out of bed or that they're picking at their IV site or their limbs and they're risk to them is usually it's arm restraints only, and consider security as required. One thing here, when you're giving physical restraints, you're going to also be providing chemical restraints. Imagine if you're just looking at these images and you have an individual that's in restraints, but had this behavior emergency so much so that you have to put them in restraints, and then not having any kind of support to help you decrease that anxiety or that psychosis. So definitely restraints aren't provided alone. It's in conjunction with some kind of chemical restraint as well. So for secure rooms, these are the three big concepts to know about that, is that security must be present to place someone in a locked seclusion room or unlock the secure room. Patients must have the ability to access basic human rights. So they have to have the ability to have food, shower, fluids. They need to reevaluate the need for secure rooms every 8 hours if they're continuously in the secure room, or 12 hours if it's intermittently used. Physicians need to be aware that the person continues to be in seclusion. Everyone that's in a secure room requires Q15-minute observation check. This is done through a camera and through the secure room window. And 1 to 2 hour patient status assessments. We need to monitor risk for harm and appropriately toileting and dietary needs. So when we place somebody in restraints, the decision to physically restrain a patient or client here is made the decision to physically restrain a patient or a client is made by the provider, the physician, or the nurse. A restraint can be implemented before obtaining informed consent, but the provider must be notified. So for forelimb restraints in seclusion room, this order needs to be provided to you within 1 hour. What this time frame of 1 hour means is that there must have been an event that led you to have to put your patient into restraints. So this could be formulating a team, like getting security there, getting medication there, like, controlling the environment or the situation, and informing the physician of that within 1 hour. For all other restraints, that's as soon as possible or within 8 hours. Now, this would be for like ongoing care that was already established that restraint was needed.
Code blue, Providence 7 Alpha. Code blue, Providence 7 Alpha. Code blue, Providence 7 Alpha. Code blue, Providence level 2 GI clinic.
Sorry. Consent should be obtained within 12 hours of initiating restraint for ongoing purposes. This is from the substitute decision maker as well. And whenever possible, the patient or substitute decision maker should be involved in the decision and care-making processes. So this is for maybe long-term care or ongoing care. There should be a care plan. So just look in the chart for that. So putting all of that together, we're going to go through a scenario here. So first of all, you're going to attempt to de-escalate, implement restraints, and maybe call the code white. So what do we do? So for example, a patient you've observed them, you've come on shift, you got handover from the nurse from nights that, the patient has slept through the night, but has just woken up and is in their room. You find that the patient now has come out of the room, they're pacing up and down the hallway, they appear to be mumbling under their own breath, appear to be a bit flushed. You attempt to engage with the patient and ensure that their needs are being met. You perform a pain assessment, you offer PRN medication to help the patient, and at that moment in time when you're engaging with them, they pick up a chair and you notice another co-patient coming down the hall. So they pick up a chair and they start throwing the chair at the wall. At that time, you see, okay, well, I attempted to de-escalate. This isn't happening. This person now is having an outburst. They're throwing a chair around. There's another patient in the hallway. At that time, if you have a personal protective device on, you can call a code white, ask your colleague to call a code white. Maybe they've seen it and have called security as well. So code white's called, they're increasingly agitated. They're now, you've stepped back, you've provided space to the person, but your colleagues have got the other patients out of the way. This individual continues now, they're maybe a bit more hostile, they're threatening, in the sense of they're wanting to leave, they're, very agitated. You're not able to de-escalate them. So security arrive, you and your colleague are able to put the patient in restraints without any harm. The security help assisted you, you got them on the stretcher, they've been placed into restraints. At that time, the physician is notified, it was given orders for sedation. So you provided some lorazepam and some loxapine for agitation and aggression. And within about 30 minutes or so, you're continuously observing your patient. They're able to engage in the conversation. So they're calmer, they're more engaged in the conversation with you. They've de-escalated this, or now you have de-escalated this with them. They said that they felt that their needs weren't being met and they were having severe pain and they were being frustrated about being in hospital, and you were able to debrief with them, and the patient understood and was able to share why they had this outburst. Restraints can be removed at that time. You've completed your assessment with them, they're able to become, they're more settled, so they can be removed and discontinued. So here, select the least restraint possible, chemical, physical, and then this is what the order will look like on the far right. So in inpatient areas, it's restraints adult that you order through Cerner, and in the emergency departments, ED restraints adult. So here, always reassess if it's working or not. So evaluate the restraints, consider other treatments if required, document this, and document the restraint as soon as you're able to, as soon as possible in the patient chart. So like I said, response to restraints, like, are they getting better? Is there still risk of harm? What's the physiological status? When someone's in restraints, now they're restricted to movement for their own body. Are they able to maintain their airway? Is the skin color or circulation under the restraint on your limbs? Like, have you noticed that they're cool, or are they, hands are cool? Do they need to be repositioned? Any adverse reactions to the restraint? Sometimes people can become more agitated in restraints, like fighting the restraints, even with sedation on board. So sometimes it's when you release the restraints, people can settle. When they're sedated under chemical restraint, they will settle with the removal of the restraint. But it's continued observation, continuous response to the interventions that you provided. Does the patient need fluids or toileting, clean linens? Everyone's on Q, here it is, Q 15-minute observations until they're stable. In someone in a seclusion room, it requires Q 15-minute observations the entire time they're in there. You need to be able to make sure they have a respiratory status. So again, when someone's placed in physical restraints, it's Q 15 minutes, observation times 4. So that's for 1 hour. and then every 30 minutes, and then 1 hour. Now, this is what the policy says. But I would say that in practice, somebody who's in restraints, you need to consistently be observing them. Okay. And then documentation occurs as close as possible to the time of care is provided. And this includes assessment, planning, alternative interventions, the use of restraints, evaluation of the restraints. So documentation area differs by area. So make sure to discuss this with your educators on your unit is where you document that. And also think about trauma-informed care. So involve the patient in your care plan, and as well as yourself. Like, how do you feel that this event happened? How do your colleagues feel? You know, and think about, it's quite an extreme event to put someone in a secure room or into restraints. So this should never be normalized. It is part of care. It can be, and safety. But, you know, do document or do debrief that with your patient. And also you can, you know, debrief that with yourself, or if you, your CNL or leader, like on your unit, if it's troubling for you. And also every unit should have a dedicated space to store restraints. So check this out during your buddy shifts. Restraints shouldn't be put in the dirty hamper for laundry. There's a specific place for them, and they do get lost. Yeah, so we kind of went through that quite quickly. So if there's any questions, I just want to thank you for your time. Sure.
We're carrying on. Our next topic is oxygen therapy, and I have here with me Michelle Duongo. She's the interim site lead for our RTs, and she's going to tell you what resources we have here at Providence.
Hi there. Good morning, everybody. I'm a little rough on doing this. I haven't done this presentation quite a while. So I'm going to just present a overview on respiratory therapy and oxygen therapy that will be applicable to both St. Paul's and Mount St. Joseph sites. A few of the other sites have very limited oxygen therapy as well as resources. So I'll just begin. For online manuals, this is located on the intranet under shop. You'll find all the oxygen therapy protocols that the RTs and the nursing staff follow. So just access under oxygen therapy acute, that's where you'll find all the information you need in terms of equipment, flow rates, and so forth, but I'll explain that later on in the presentation. For acute care RT coverage, so this is going to be applicable to St. Paul's. One ward RT, so one RT is covering the 5th to the 10th floor. We have a dedicated emerge RT, and then we have 3 RTs covering the ICU and CICU, as well as one RT covering CSICU and PACU. So we're 12-hour shifts, so very similar scheduling to nursing. And at Mount St. Joseph's, there's one RT covering the entire hospital 24 hours a day. We're all accessible on pager, as well as we have an emergency cell phone as well for access. So for calling the ward RT, we are also the CCOT RT as well. We have both hats when we're working on the wards. So it's very helpful for you to just have the information ready in terms of the O2 saturations, code status, All you're familiar with the S-bar, and it just helps the RT to set priorities to whether they need to drop what they're doing and come to see your patient. For RT roles and responsibility, this is applicable to the wards. In particular, in critical care, they have different roles, but on the wards, we set up any titration and high flow oxygen. Our primary mode of delivering high flow oxygen is the OptiFlow system. We care for anyone with our artificial airway, so that's a tracheostomy tube. This is a shared responsibility that we have with nursing. So our trachs are put in the ICU mostly by percutaneous. Very few actually go to the OR for an open trach, so they could end up onto any medical floor. Any patients requiring 50% or higher, the RT must escort the patient to the procedure. So as soon as you hear there is a patient that needs to go to, say, a CT scan, for example, let us know. As well as your tracheostomy patients, they need to be escorted. These patients will be traveling with the porter. If the RT wasn't there, sometimes they run out of oxygen, so we're there for safety. So please let us know ahead of time if you can. We also do sleep studies on the unit. So this is ordered by respirology. We'll let you know if one's been ordered in terms of what that entails for you and things to watch out for during the night. We also, as a result of if a patient is positive for a sleep disordered breathing, BiPAP or CPAP can be ordered, and we'll do the titrating and teaching. Most often these patients are coming for surgery and can be from out of hospital, so they're encouraged by their physicians to bring in their CPAP units. In some rare cases, they may have forgotten their equipment or they didn't have time due to the urgency of transfer. So we do have some available units for loan. So let the RT know if there's you do have a patient in that situation. Arterial blood gases, this is a shared responsibility that we have with the residents and physicians. If by chance they do give you the blood gas, it's one of those blood gases that are, it'll say order to unit. So just if you're not sure how it's handled, it should be sent to the lab stat, no ice needed, or call the RT and they'll give you a direction as to how it should be sent to the lab. Other areas we participate in and do assessments is home oxygen referrals. So we follow the criteria for the home oxygen guidelines to see whether the patient needs oxygen for discharge. So let us know if you see there's a patient that is looking to go home, but it hasn't come up, and we can do those assessments on the unit. And definitely, your RT is your resource. We're here to help and support the team. So any patients where you have any respiratory concerns or it's equipment related, we're easily accessible by pager 24 hours a day. I mentioned about trach care. So this is a shared responsibility. There's a dedicated policy and procedure regarding trach care. So there's a lot of things, like pretty much say 9 out of 10 things the RN can do. The only thing that probably is not on the list is doing a trach change. So if you haven't suctioned a trach in quite a while, your resources are your clinical resource nurses, you've got educators on the unit. So please ask them for help, as well as when we come around and see the patients, we'll ask you if you have any questions. Because a lot of these patients are trached for bronchial hygiene, so they do need regular suctioning. So that is something that you should feel comfortable when you take on this patient as your primary patient. So things that we're involved with is cuff deflation. Usually according to our protocol, none of the patients will come to unit with an inflated cuff on their trach. We do corking trials. We change the trach on a monthly basis. Checking cuff pressure is more in critical care. Rare occasion, these patients might go on the ward, but they're usually for end of goal care where they're for comfort and it's too dangerous to have that cuff deflated due to some sort of airway cancer and so forth. And the RT is present at all swallow assessments. as a nurse, when you do come on the unit and you have a trach patient, make sure you've got functioning trach suction at the bedside, as well as the trach safety bag. So shared responsibility, checking to make sure that all the equipment's functioning properly, that suction, the patient's on the right O2 flow. Suction is super important, making sure that the liner is not full because it won't work. Trach care, all of our trach equipment is disposable. The inner cannulas are disposable, but they are size specific. So tie and dressing changes, it'll get soiled quite a bit, but usually tie changes are just PRN when they're soiled. And again, initiation, titration of oxygen via nasal prongs is anything that the LPNs and RNs can do based on the oxygen set goals for these patients. In the rare occasion, well, actually not rare, more often than not, a lot of these patients have chronic lung diseases where it's more appropriate that the doctor has ordered set targets for 88 to 92, and this is in your COPD population. You have to set up short-term emergency oxygen therapy. So if you've got a patient on nasal prongs, you've titrated up to 6, you can start a simple mask. Our protocol is 10 liters a minute, just because 10 is quite easy to remember to prevent rebreathing. And the patient can only be on the simple mask for about an hour before you have to decide, should we consult RT to see whether they need high flow? And that's just built into the protocol just so that we're identifying patients that might deteriorate rapidly. Equipment assessment, your equipment check at the bedside each morning would be, like I mentioned, making sure that your oxygen's set appropriate level. We want to encourage weaning of the oxygen, titrating it down. We don't need to keep sats like at high 90s. Correct flow rate, we want to make sure. For the humidification bottle or chamber, this is quite old. This is going to be your water bag on your OptiFlow, because we no longer use the messy quite wet high flow oxygen setup. So usually the RTs will leave a bag of sterile water in the basket, so you can just spike that like an IV bag. If there isn't one there, just page them and they'll bring one to you. That's just to feed the humidifier chamber, because with the OptiFlow, we're heating the humidified gases to body temperature. If you're in critical care, you're going to make sure that the ventilator settings are charted appropriately, and we've got everything matching. Back to the trach stuff. So your emergency trach bag is going to have a extra long trach tube, so it fits all sorts of patients. It's going to be our emergency size, so it's your number 5 proximal extended length trach. We're going to have dilators in there, a pair of scissors, and a syringe to inflate a cuff if it needs to be inflated. As well, depending on code status, whether an ambu bag and mask will be at the bedside. On each unit on medicine, being say 7A, for example, it only has one bagger at the nursing station. So when that's used, the RT will bring one after a code's called to replace it. I believe it's either the CNL or the unit clerk's going to check when the start of the shift to make sure that bag is sitting there where it needs to be. So when your trach patient goes for transport, this bag is going to go with them as well. The RT will be there as well, unless in the rare case that this patient's chronic, they've come from the community, it may be safe for them to leave the unit on their own with the porter. But if any doubt, just call the RT, and that's a discussion you can figure out if the patient's safe to leave on their own. For respiratory assessment, these are your basic assessment things that you would chart in Cerner. The rate and quality of respirations, you're going to listen to breath sounds, especially someone who's got COPD or asthma with wheezing and not. A lot of these patients are on inhalers. Chest shape, skin color, vital signs, and O2 sats, and level of consciousness. For oxygen saturation, the most common way of measuring this is probably really basic. I don't remember writing this. Is by pulse oximetry. So we do not have cerebral head probes available on the unit. They're not compatible. These are only available in critical care units due to the cost and so forth. But always check with what measurement you're getting and does it match the clinical picture. And know whether your SAT reading is reliable. On the machines on the wards, they have a blinking bar graph to show signal strength. A lot of our patients are cold, peripherally shut down. So sometimes trying to warm that limb where you've got the probe on can be helpful. I find they don't pick up on gel nails, so it maybe use their toe. And also if they have an irregular heart rate. So something like, say, atrial fibrillation, it might be take a little bit of time before you get an accurate reading because the heart's fibrillated. You might not get perfusion to that limb very quickly. So for troubleshooting, these are things I mentioned. Yes, being cold or someone on hemodialysis, they're really peripherally shut down. Try and warm. That's the easiest thing you can do. Try different fingers, toes, sometimes the ear if it's the lobe's large enough. These are different ways of trying to get a SAT reading. So for equipment-wise, the simple math I mentioned, it's only short-term. For only an hour, after an hour, or even within the hour, you think this patient's not going to turn around, by all means, give us a call to assess the patient. Reminder, this is not aerosol generating, but if we need to go to high flow oxygen, we're probably going to have to do a RAT, especially if that patient is in a multi-patient room. So the RT is responsible for the initial setup. If we have to titrate the oxygen up or down, we will communicate that with the primary RN. And we're titrating oxygen to the saturation targets written by the team. So for RN responsibility, you're noticing if there's any changes. Some of these patients might need oxygenation before turning, getting up, and so forth. So that's something that'll be established if someone has labile SATs, a plan in place in how to avoid these big desaturations. We usually primarily administer the high flow oxygen by nasal prongs. It's more comfortable, patient can talk and eat and so forth, but there are other options such as a mask, but with that, it has its disadvantages. So it provides optimal heated humidity to body temperature. So it's very helpful in patients have tracheostomies or have a lot of secretions, that it'll help move things around and help clear up any, trapped secretions. High flow oxygen just is an example of what it looks like. Talked about the different interfaces, but it's most ideal. We can deliver oxygen up to 100% and the patient can still talk and eat. I guess since the pandemic, we've switched away from nebulized medications. The primary mode would be by an MDI, or if it's drugs like Symbicort, you'd have dry powdered inhalers. All these aero chambers are available on the ward. Whenever someone's prescribed an MDI, please offer them an aero chamber so we can optimize drug delivery. And remember, a whistle is not a good thing. A whistle means you need to slow down the breath in. We don't want to hear, that's feedback to slow down the breath in, so we're avoiding the drug from hitting the back of the throat. For nebulized meds, if that's the only way to effectively give it, we have air flow control valves. They're either on or off. In this horizontal position, that's off. In the 6 o'clock position, that would be on. And this is straight up air, and it's visually different from the oxygen flow meter, just to avoid inadvertent of administering medical air instead of oxygen. For going off the unit, so patients that are on high flow that need to go on transport to procedure, the RT will provide a non-rebreather mask. That's the highest amount of oxygen we can provide on transport. And it's not, again, not aerosol generating. We do have special masks called Flow O2 masks for patients who are COVID positive or we're still determining effectiveness. They will have multiple valves on it, but then again, it's DRT that will provide the mask, and you'll see it. It has a bag similar to this, but has multiple valves so that the exhaled gases will be filtered. I think that's all I have to present in a nutshell. If anyone has any questions. Yeah, good. Is it off? Oh, okay.
Thank you, Michelle. I'm just waiting for our next presenter to come. So if you need to have a quick stretch break, have a quick stretch break. The next presentation is in 3 minutes. Thank you.
Thank you. All right, good morning, everybody. I'm very happy to be here and chatting with you. Hopefully we'll meet some of you in person next week. Before I start, I do like to acknowledge that I'm making the presentation from the occupied and traditional territories of the Coast Salish, the Musqueam, Squamish, and Tsleil-Waututh nations, and that I think that it's very relevant to talk about what Providence does with regards to truth and reconciliation and how that can be connected to your own nursing practice and your own wherever you end up in any of your care units. And in particular, making sure that you've all taken the time to go onto PHC Connect and look for the resources under our Indigenous Wellness and Reconciliation team, and specifically this action plan that was produced in 2022 that comes from our Indigenous Wellness and Reconciliation department, and making sure that you're aware of what the goals are. There were goals for 2022, but there's a 5-year sort of plan, and looking at that and understanding what those different, there's sort of 4 different categories, and how that overlaps with your own personal practice and also within your care areas, and how your care areas themselves can contribute to reconciliation. It's a fast and furious hour we have together. I will try to touch on all of these things, mainly just kind of the scope of care we're looking at and where to find more information, because obviously you can't memorize everything I'm saying. And then we'll spend about 15 minutes walking through the steps of talking to folks, walking through somebody on take home naloxone. So what are the steps when we're pulling out one of those kits and offering up to somebody and making sure that they know how to use it. You can use Slido to ask any questions, and they'll please feel free to ask questions. I'll pause a couple times, but at any point you can ask questions. So I think that this sounds really boring and dry, but it's actually kind of revolutionary that our health authority actually has a policy on paper that you can find on SHOP that talks about their intention of working with people and ensuring that people who use substances have equitable access to healthcare, and that in the understanding of that in providing equitable access to healthcare is that healthcare providers will use a harm reduction approach to care. And this is a very powerful tool because it translates to a lot of things in action and a lot of things that you will have accessible in your practice. I also want to draw attention to another long document that, but again, that really supports all of the things that I'm saying. So again, I might, be under the urban health department, but really these are everything that I'm talking about comes from this broader philosophy of Providence Healthcare and their intent of working towards social justice and working in an innovative way. So the Harm Reduction and Managing Substance Use is a guideline that you can, again, find on SHOP. I really like looking at it online because it's quite long and it's got a lot of hyperlinks, so you can just kind of go to the place that's most applicable to what you're looking for. But again, it just really supports this harm reduction spectrum within the practice. And I know it says acute care, but it absolutely has things that would be applicable in long-term care. And it's nice, it has some conversation guides and just a lot of general information and quite a lot of appendices that support the document. St. Paul's is often in the news with regards, and Providence in general, with all that it's doing to support people who use substances. We have our overdose prevention site has garnered a lot of attention. And I know that also this August 31st is Overdose Awareness Day, and our security guards for the last year, almost a year and a half, have been equipped with nasal naloxone and have reversed many, many overdoses at this time, and that made the news quick. And then also in this past year, we were mentioned in the New York Times article, a very interesting kind of look at what Vancouver in general is doing, and definitely St. Paul's was in there. So I think that it's just, again, something that St. Paul's is and Providence is known for, that we're known for this innovative work, that it's intentional, it's not accidental. And I think we can hope to continue to be global leaders in this area of medicine. In general, I think we often think of harm reduction just as sort of like clean needles and, condoms. But the reality is it is quite a large concept, and it's a very pragmatic concept. It's very evidence-based, it's kind of very common sense, and it's really about, making healthcare accessible and making opportunities accessible for people. And so I encourage you to think of all the ways that, we engage in harm reduction that aren't related to substance use. We often talk about seatbelts, sunscreen, I would say COVID vaccinations. These are all different pieces of harm reduction. And I think that it's important to see it as that large kind of spectrum and not just this one tiny little thing. So when I talk about this philosophy in practice, this is what comes to mind for me. Maybe at the top of the list is that Providence has an addictions medicine consult team as a multidisciplinary team that I'll talk a little bit more about later. We have the second only in Canada overdose prevention site on site in a hospital. Technically, it's the first overdose prevention site, but there is another safe consumption site in Edmonton. Rapid Access Addiction Clinic, that's here at St. Paul's on the second floor of the Burrard Building. Providence also runs the Crosstown Clinic in the downtown east side that provides diacetylmorphine and medical grade heroin. We have many, many options for opiate agonist therapies, nicotine replacement therapies. We have managed alcohol program. And so this philosophy, there's some of these things that are, obviously very site-based, but many of these things are accessible across, doesn't matter where you're working at Providence. And then I would argue that across all sites, regardless of where you're working and if you have direct access to those resources or not, that we can always, as healthcare providers, be using the mindset that we want to view substance use disorder as a chronic relapsing condition, and one that is very linked with the social determinants of health. And we want to create an environment of equitable access to healthcare. So really be asking ourselves, how can we do that? And what resources do I need in order to do that? What information do I need? What education do I need? And we can really work towards having open communication with people about substance use and then trying to provide proactive treatment. So not really trying to move away from a judgmental, moralistic viewpoint, and also sort of a don't ask, don't tell. Like, I don't want to know that this is happening because it makes me uncomfortable. So I'm not going to ask any questions about it, and I'm going to kind of avoid it when it comes up, which actually, really decreases safety for our patients and also for ourselves. when I'm talking about patient safety, I think we can't talk about working with folks who use substances without talking about the fact that we are closing in on our 7th year of a provincial pandemic, which is also, affecting people globally. Certainly in British Columbia, these are just a few headlines that I took from kind of August, September. And it's quite shocking. We look at the number of folks that are dying every day, we lose about 6 people in British Columbia every single day to the toxic drug supply. And I bring up this chart, and not in any ways to diminish the death that have been caused by COVID-19, but as a way to compare our responses and the ways in which the efforts that we've gone to mitigate the risk of death from COVID versus the efforts we've gone to mitigate the risk of death from overdose or drug toxicity. So I think that's a very important point to be thinking about, and then to be asking ourselves in our own practice, how can I contribute to safety? And there are lots of ways. There are lots of ways that we can contribute to safety and to mitigate risks. Just like, when we ask our patients about COVID symptoms, we know that's, a protective measure for them, for the other patients, and also for ourselves. And when we ask people about substance use in a non-judgmental and proactive way, that's also about safety and building safety for our patients. I think it's also important to note that, we're also seeing across the board just an increase in substance use overall. We've seen a large increase in people admitted with alcohol-related harms, and that's across Canada. And certainly anecdotally here at St. Paul's and Mount St. Joseph's, that's what I've heard from nurses as well, that we're seeing more and more people coming in that will be going through alcohol withdrawal, which, if we don't have as much information or we're not as familiar with those assessments, then that can be really challenging. And how do we take care of those people? When we are very fortunate to have an addictions medicine consult team. They are based here at St. Paul's, and I'll talk about how to access them if you're working at MSJ. But as I mentioned, they are a multidisciplinary team. We're very lucky to have so many people working on that team and have seen some expansion in the last year. We now have 4 physicians on at any given time, and we have a liaison nurse that's available 7 days a week now as well. Usually your patients are going to be consulted to AMCT in their emergency, like as they come through the emergency department in that admission. But once they're up on the unit, and if you think that is something that hasn't happened and that's clinically indicated, then just let your clinical nurse leader know, your CNL or the most responsible physician, and they can put in a consultant Cerner. And then once your patient has been consulted and is followed by AMCT, then a nurse can call anytime between 8 and 5 directly to the physician, and you can either find out who's following your patient. There's often sheets at the nursing station at the clerk desk. Or you can call switchboard. So when would you want to call them? So certainly if you're having, if you're confused about what the care plan is, if you don't understand sort of what's being laid out and you just need some more information, if you don't think that plan is meeting the needs of your patient, if they're, having to use a street supply, they're not getting relief from what's currently prescribed, if they're, going through alcohol withdrawal and receiving medication and it's not having the intended effect. Certainly anytime somebody has an overdose event, even if it's managed at the bedside with just nursing without, being a code blue, we would still want to let AMCT know so that they can work with that person to hopefully create a care plan that's going to be more effective for them. Overnight, we don't have direct access as nurses to AMCT, so it is a physician-to-physician consult. So we would be calling whoever's cross coverage and then advocating that they contact the consulting service. There are times when, maybe that's a hesitation for folks to, wake up somebody, but I just put down a few examples of times where I think that it is really appropriate for us to advocate and that we need their expert advice. Certainly small little things or just purely behavioral things, that's not really appropriate But anytime that, person's safety, that their medications that are prescribed are ineffective, then we want to have AMCT weigh in. Just wanted to let you know that AMCT currently sees about a fifth of the population. They're following about a fifth of the population at St. Paul's. I don't have a corresponding number for MSJ. We're still trying to get that data. But in the last few years, we've seen a 660% increase in referrals to AMCT. So just a bit of context for you on, thinking about, the education that you've received so far with regards to substance use disorder, and, regardless of what area of you're going to go practice in, that you're certainly going to be working with people who have substance use disorder. So when I'm talking about these different resources, it's really good for you to be aware of them, because they're going to come in handy, because it's going to be part of your practice, even if that's not what you ever intended on doing. And this speaks to the patient population that we're working with, and this is part of Providence Healthcare's mission and their intention of working with our patient population. So it also explains why AMCT is so big. So we are very lucky to have a resource nurse that works with the physicians and also with our peer. And they're available now 7 days a week, 8 to 4. That's their cell number, and they just share that cell. It's 2 nurses that just rotate through for that coverage. And they are nurse resource. So you can call them if you're just not sure, something doesn't make sense to you, you feel really uncomfortable, you've never done something before. And they can, just kind of talk you through it on the phone. They'll even just text with you, or they'll come to the unit and kind of review a chart with you, go in and do an assessment on a patient with you. And sometimes they do also get called in when there's complex care planning involved and just trying to, contribute to that patient safety. So there are their faces, Danielle and Anton, and you hopefully will see these posters all over the hospital, in the nursing station, with this phone number, trying to make this as readily accessible to you. And they both work very closely with our AMCT peer. So a peer, if you're not aware of it, is a person with lived or living experience. And in this case, Karen has lived experience of a substance use disorder. And so is really a liaison for our patients and our clients. So is somebody who can maybe make contact with folks that are really withdrawn or disengaged from care. They, for very valid reasons, have a lack of trust in healthcare and healthcare providers, have experienced a lot of stigma in previous hospitalizations. And so our peers work amazingly well at kind of as a bridge. Often Karen refers to herself as a bridge between the patient and the physician, and just being able to, support somebody, be a safe person, get some collateral information. And Karen doesn't work in Cerner, so it's kind of separate from that very hierarchical clinical setting. You'll see her everywhere, and often on the 4th floor garden talking with folks, making her own. She gets a lot of referrals from all over the place, and we do filter them through. As I mentioned, at any given time, AMCT is following probably at least 100 patients at St. Paul's. So we only have one peer. So we do try to make sure that the requests that are going to our peers are appropriate. So if you want to make a referral to the peer, then you contact the AMCT liaison nurse. So going back to this idea of viewing substance use disorder and moving away from this very moralistic perspective that I think is still the most prevailing kind of attitude in society, that, addiction is a choice, that it's a bad choice, and that, if people make a bad choice, they deal with the consequence. When science tells us something different, science tells us that, this is a chronic relapsing condition, one where we can expect, periods of remission and periods of exacerbation. It has very similar relapse rates to congestive heart failure or diabetes. But the thing about substance use disorder is because we have, an unregulated supply, and we have, some drugs that are legal and some drugs that are illegal, is that for folks that are using substances that are illegal, there's this criminalization of relapse and a stigmatization And then this really goes hand in hand with just an incredible level of isolation and disconnection. And I think the one piece that I always like to point out when we're talking about this sort of medical clinical perspective, which is very useful and essential in a healthcare system, is that this medical condition is inextricably linked with the social determinants of health. So we can't really successfully talk about substance use disorder without talking about poverty, without talking about racism, without talking about, concurrent mental illness or, acquired brain injuries. So it's a very complicated issue, but we shouldn't shy away from talking about those pieces of it that are quite complicated and sort of interwoven with each other. One of the things that I think, if anything gets taken away, is this kind of comfort of talking to people about withdrawal and trying to treat withdrawal and really prioritizing that. For me, that's a priority when I'm working with somebody, and I will often say, it's the very least I can do is make sure that you're not in withdrawal. So I like to ask people, do you have any concerns with withdrawal or cravings? And I want to treat them, and it's serious to me and it's important to me. There's no scientific evidence for us to just have people suffer through withdrawal. In fact, the research tells us that that's, where people live, patient-initiated discharges, where they're much higher risk for an overdose death, and much higher risk for not engaging in harm reduction strategies that can keep them safe. So I often talk about withdrawal as very similar to pain. So we want to treat pain early. We know we can be more effective, more efficient with less medication. Withdrawal is very similar. If we treat withdrawal early, we can be more effective, more efficient. And then that person, if their withdrawal is treated, now we can actually work with them about why are you here? You're admitted for an acute medical reason. Let's get you better. And really, this relies on us not being the experts. We don't know everything about withdrawal, and we don't know what people's personal experiences are. So this is kind of a point where we can disrupt that hierarchy that exists so extensively in the healthcare system. Is a very hierarchical system, and the patients are really our experts, and they can tell us what's going on for them, and we can believe them, and we can work with them. I really like, with PRNs, I do think we want to move away from this sort of gatekeeping that we're somehow, policing people's doses, when really I want to let people know, hey, did you know you have this available? Let's make sure you get some doses so that you're not going to go into withdrawal, and being a little bit persistent. If somebody's not interested or they don't want them, is it not effective? Is the medication not effective? Is the route not effective? The frequency. I want to work with people and find out how I can keep them here to get the medical treatment that they need and keep them safe. And so even if you just change your practice by adding one question, a couple of years ago we added several questions about all the COVID symptoms that we know are common, even got built right into Cerner. Certainly we can fold into our head-to-toe assessment one question: do you have any concerns with withdrawal or cravings? And we don't ask that just to people that we take one look at and think, oh, I know this person uses drugs. We can ask everybody. Do you have any concerns with withdrawal or cravings? That's just, creating this normalization of something that affects so many people across Canada. And it's okay that we don't maybe know if people answer back, and they actually do let us know, and they talk about things and it's slang or words that we don't even know. That's fine. It's okay. We don't have to know everything. And that's actually a great time to be like, oh my gosh, you know way more than me. I feel kind of silly. I'm not even sure what you just said. Do you mind explaining that a little bit more? It's a really great time, like I said, to, give up some of this unnecessary power that we have as healthcare providers, and let the people that we're working with tell us what's going on for them and what works for them. And always, I think, like as an undercurrent of just genuinely remaining curious and being curious about what people's experiences are is going to go so far. It creates an incredible rapport, which I argue also creates an immense amount of safety for your patient and for you as well as a healthcare provider. So just remaining curious and wanting to help people, that's going to take you a long way and really create more sustainability in your career. I'm going to talk a little bit about what is available, but I do like, as far as like specific treatment options, I won't go into in detail about every single one, but just sort of overview. I do want to say that everything I talk about is available on SHOP. Sure, you've heard about SHOP a million times. I know. I just thought it was super boring until now I use it all the time. But I mean, I know we're not always available. Like, you know, I work Monday to Friday, 9 to 5 in this job. You know, our liaison nurses, even though they're 7 days a week, they're, you know, not here in the evenings or overnight. So if you really are stuck, like, this information does exist. The information to support your nursing practice does exist, and go and look for it. We try very hard to keep it up to date. I just will pause here before I go into this in case there's any questions. And there might not be, and that's cool. Pardon me? No questions. Okay. The one thing I like to point out, so this is from the PC Center on Substance Use, this little infographic. And the one thing I really like to point out, so, you know, when we're working with people, and maybe what it comes across your, you know, on the chart and on their MAR is something that seems really extreme to you, and it's hard for you to understand why are we prescribing medical grade heroin? That seems nuts. Isn't that the opposite of what we want? And I do like to point out this continuum of care. So for most folks, when they've been diagnosed with an opiate use disorder, they're going to be prescribed medications like methadone or buprenorphine as a withdrawal management. So we're going to safely have this person withdraw, keeping them safe from relapse, keeping them safe from our toxic drug supply. And for some people that works really great, and they're able to, you know, they carry on with what their plan is, maybe their plan for recovery or abstinence. And that's wonderful. And then for some people, you know, that might not be really successful. And so we want to increase our treatment intensity because we still think it's important to value this person and keep them safe. So we can use buprenorphine and some methadone as a long-acting therapy. So this is where we would call them like opiate agonist therapies, that they're going to take this medication over a long period of time in order to prevent them going into withdrawal. And really, that's the point of an opiate agonist therapy, is to prevent somebody from going into withdrawal. And for some people that works really well, and maybe they take them for maybe they take them for years and kind of on continuation, and some people might be on them for years and then taper them off and you know, attempt for recovery, or in that, I guess they're already in recovery, but they titrate down on those medications, and that's great. And for other people, if it doesn't work and they're still at risk for overdose from a toxic drug supply, they're still suffering in withdrawal. And so then we're going to increase our intensity and look at things like slow release oral morphine, which is most often we see prescribed as Cadian, which is a 24-hour long-acting medication, or we see injectable options such as diacetylmorphine or high-dose hydromorphone. And moreover, in our community, we're also seeing people being prescribed fentanyl patches, or in the hospital, we do have IV fentanyl available for withdrawal management. And honestly, because the drug supply is continually changing, we're always going to have to be, you know, offering options on that treatment intensity on the higher end of things in order to keep people safe and keep people alive. So when we see those high intensity orders, it's important to understand that, you know, likely there were years of trial and error around, you know, can we do withdrawal management? Does this medication work for you? What about this medication? What about this combination of things? What about that combination of things? And to recognize that it's taken people years to get there. They don't just pop in and start on the highest intensity medication. I like this chart because it just it kind of shows what the goal is. So medication assisted therapy is another way of saying an opiate agonist therapy. So, you know, what we're trying to do is just maintain people in that normal blue kind of realm, that as people have developed their tolerance and physical dependence, they move away from experiencing any type of euphoria, and they're just really kind of bouncing in between withdrawal as the baseline feeling, and then using the substance to achieve like a normal feeling, and then going back and forth between withdrawal and normal. And so when we offer people that medication that keeps them out of withdrawal and then maintains them in that normal range. That's really the goal of an opiate agonist therapy. And this is what we have available sort of in its treatment intensity options. Suboxone is the brand name for buprenorphine. Sublocade is an injectable form of buprenorphine. Suboxone is an oral form. Methadone is probably one that you're most familiar with. It's still, even though it's not considered the first line, it's still the most common. Kadian and Emaslon being our slow release oral morphines that come in a pill, like a little pellet capsule. And then we have our IV opiate options. And I guess I can actually add in here some fentanyl patches. So just looking again at what are the symptoms for opiate withdrawal, what do we want to keep our eyes out for? And my number one thing always, as I mentioned before, is I'm going to ask somebody, what are your symptoms? And I'm going to believe them when they tell me their symptoms. I don't want to see someone's symptoms of withdrawal because that tells me that we're really getting up there. It's getting really intense. It's going to be harder to treat. So I'm really happy if somebody tells me, man, my legs are really starting to ache. I just feel crappy. I don't know. My tummy is kind of like, I don't know, it doesn't feel so good. I know what's coming. Then that's the time I want to treat someone's withdrawal. Obviously, I'll treat it at any point. But I did want to point out the objective signs because sometimes our patients can't answer our questions. So they might be confused. They might be sedated for reasons other than opiates. And we still would want to treat their withdrawal. Again, there's no scientific basis for us to have someone suffer through withdrawal. You know, that concept of cold turkey is not evidence-based and in fact puts people at risk, very high risk for a fatal overdose, even because they're going to be inclined to treat their own withdrawal. So you can go in interactive view. These are two clinical tools that are available to you. COWS is the clinical opiate withdrawal scale, which has the signs and symptoms of withdrawal, and you can put them in and it will create a numeric score, which can be a very, useful communication tool if you're advocating for someone to have more adequate treatment for their withdrawal. And then the other tool that you'll use very frequently is the Pacira opiate sedation scale. So this is a scale that's measuring someone's level of sedation, and then that's kind of what's you use for your clinical judgment on, is this safe to give a subsequent dose or a dose of an opioid. And that one is pretty much always ordered by AMCT anytime they have someone with an opiate use disorder, that any medication that's prescribed will refer to that sedation scale. When we're talking about folks that are working with an alcohol use disorder, really what we're doing are we have the 2 withdrawal assessments available and then the managed alcohol program. So you're probably very familiar with CWA, as that's kind of used across different health authorities and is a very standardized scale. There's obviously a great time and a place for that. And we've also found ourselves really struggling to find a tool that can work with some of the patient population that we're working with, as CWA was not intended or researched for a lot of the folks that we're working with. So the objective alcohol withdrawal scale is something that can only be ordered by AMCT, and I'm going to talk a little bit more about that. CWA, if you're familiar, that has sort of 10 categories. Of those 10 categories, 7 are subjective. So it requires your patient answering questions, which can be really challenging if they can't answer questions, and it's pretty much impossible to do with CWA. Or if they have, baseline symptoms that are present that are showing up, and how do you differentiate your score based on, well, they always have a tremor. I don't know, is this tremor related to that, or is this tremor related to alcohol withdrawal? So that's really where we see the limitation. So often AMCT will order the objective alcohol withdrawal scale, which is unique to each patient. So it changes every single time, which is maybe its strength and its weakness all at once, because the strength of CWA is it's the same every time. Essentially, after you've done it so many times, it's memorized. You know exactly what questions to ask. You know exactly when to give medications based on their score. Whereas O's is the opposite. It's not the same every time. It changes every time. It's unique to each patient. And then you're going to have to constantly refer back to the order to figure out when what criteria are you scoring on? What is the threshold for giving benzodiazepines? So I cannot stress enough that you definitely need somebody to walk through O's before you do this on your own. Pretty much we see an incredibly high error rate for folks that just try to wing O's. Yeah, and then for both of these, we're really wanting to appropriately initiate them. So really, we want to start these orders, which it's kind of counterintuitive, because as soon as they're put into a Cerner, they're active orders. But we don't want to start them too early. We really want to be initiating alcohol withdrawal assessments when we start seeing those first signs of withdrawal, so we don't miss anything. If people are on Q1H assessments, we definitely want to wake the patient up and try to do every indicated assessment. And ensure the assessment was properly initiated. Yeah, that can be a bit tricky, but it does require a little bit of a chart review. And I do like to point out that when you're having patients that are coming in on CWA and O's, this is a workload consideration. And so that's kind of also one of the reasons why I pointed out that there's that 10% increase. And sometimes, when folks coming in with substance use disorder as part of their medical picture, it doesn't always get translated in our minds or in the minds of the people making up the assignments of the level of acuity. So even somebody could be kind of walking on and off the unit, but they're still, have a level of acuity that requires time and effort on their nurse's part. C1Os are time intensive. It does require, close reading of the chart to understand what you're actually dealing with. So I just want to support that. I know that's like great in theory, but hard in practice when you have a really busy assignment. So I do want to acknowledge if it feels hard and frustrating, it is hard, that the documentation is there, and please reach out, specifically for O's. For some folks that are not going to be abstinent from using alcohol and are at risk from using non-beverage alcohol like hand sanitizer or mouthwash, we will use a managed alcohol program. So that's providing safe doses of alcohol at regular intervals to prevent them going into withdrawal. And for the most part, anybody on this program in the hospital is already on this program in the community. So we're offering like a continuity of care. And so each shift, you're going to let that person know, hey, you're on MAP. This is what you have available. I can give you a dose, this often, and make sure that that they are aware that they can have those doses. If they just take 0 doses in your shift, then they're going to go into alcohol withdrawal. So every shift, we would also use CWA as a tool to assess our intervention. So we gave them doses of alcohol. Did we see any signs of alcohol withdrawal? If we did, that would be really concerning, because also in this patient population, we know that they're at very high risk for serious alcohol withdrawal complications, including seizures and delirium tremens, which can be fatal. Just briefly mention that we do have, you'll see some risk mitigation prescriptions that came under our provincial safe supply, which is hydromorphone 8 milligram tabs and methylphenidate, dextroamphetamine, Ritalin, and Adderall that would be for stimulant use disorder. We don't really see much use of the methylphenidate and dextroamphetamine, but it is available. It would just be a PRN on the MAR. The hydromorphone we see a lot of, so you'll see those 8 milligram tabs available for people. In the community, people can go to the pharmacy and actually get a set amount to take home with them, and they can take them as needed. In the hospital, it's much more paternalistic, so we would just dole out each dose by dose, so it's just as a PRN. But we want to make that, we want to make sure people know that that's available to them and that they can have it when they need it. Carlin, my colleague, will be here shortly to talk about the overdose prevention site, so I will just leave that to her. But in general, just a couple things I want to mention about overdose response, which is, in the context of our unregulated and toxic drug supply, overdose response is more complicated than ever. I do encourage you, there is a shop document that has an algorithm on, guiding you through how would I respond if I came across somebody, within a patient or someone like that. And it kind of goes through the different parameters, and it's a very helpful algorithm. It's page 2 of a very long shop document. So I can recommend page 2. The whole thing is great, of course, but page 2 has got the kind of color-coded algorithm that's helpful. A lot of people print it out. Anyone who's followed by AMCT and on opiate agonist therapy, which is OAT, they're automatically going to have orders for naloxone. And if they don't, that's an error, and you should follow up on it. If you need to access naloxone to, you suspect an overdose in someone who's a patient, like that you don't know, or a visitor, or just an unknown person, we can always access naloxone through the Omnicell. There's a global list. It says opioid overdose, and then you don't have to pull out under a person's name. You can just grab it really quickly. And again, if your patient has an overdose, regardless of how serious it was, you do want to call AMCT and let them know, because they're going to want to follow up and talk to that person and figure out what's going on. From this part of the presentation, I hope that I have conveyed that this is a very fast-paced, innovative area of medicine. Providence is really leading. We get calls all the time from across Canada asking what we're doing and how we're doing it, and people are really looking up to us. So it's very exciting. And that everything that we're doing is evidence-based and outcome-based, so that we're really looking at how can we provide care that keeps people safe? How can we provide patient-centered care? And if you're interested in looking at the research that's available, certainly the BCCC, the BCCSU, the BC Center on Substance Use, has some really a lot of research and published papers that you could check out. And then again, just to plug, there are nursing practice standards that will support your practice in every single thing that I've talked about. And there's a lot of in-person support, and we really do encourage you to reach out to our team. That's why we're here, and we're very happy to talk to folks. At St. Paul's, you can always go to your unit nurse educator. You can contact the liaison nurse. You can contact myself. At Mount St. Joe's, there's one physician, Dr. Paxton Bach from AMCT, who's available Monday to Friday. If your patient's already referred to AMCT, then you can contact him directly. Anytime there's a new referral or for overnights on the weekends, then that would be a physician to physician. So you would advocate that the physician call AMCT. On the weekends at Mount St. Joe's, you can also call the AMCT liaison nurse. We have offered that support on the weekends. Again, your unit nurse educators are great advocates. And then myself, my role covers all of Providence. So I'm definitely available for any questions, and definitely do get calls from, Mount St. Joseph, St. Vincent, Holy Family. If you're interested in learning more, I can recommend that the UBC Continuing Professional Development course, Addiction Care and Treatment Online. Of course, it's a free course. It's not paid for you to do, but if this is an area of interest, I do encourage you to look at that. I encourage everyone to look at the In Plain Sight Summary Report, which is a provincial report on anti-Indigenous discrimination in our provincial healthcare system, and to check out our Indigenous Wellness and Reconciliation Team Action Plan for Providence Healthcare. And my colleague and I currently are providing Safe Care, which is a learning hub, like a Zoom online training for trauma and violence informed care, which is, I think, paid for by most sites. You would just have to talk to your manager. And the next session will be in January. You can just sign up on Learning Hub. So I'll just pause again here before we talk about the take-home naloxone. If there's one question, okay. Oh, that's a great question. Yeah. I would look to the Addiction Medicine Consult Team narrative note, and they write very thorough consult notes. I would definitely ask the patient when their last drink was, if they And if it was more than 6 hours, then I would initiate the CROs. And we can also always do a baseline. So if that person's drink was just an hour or two ago, we can do a baseline, but we wouldn't kind of count it as a sort of an activation. It is great to have a baseline, especially with CWA, in case there are any symptoms that kind of are separate from their alcohol withdrawal, but are similar in presentation. In general, this is more in the emergency department, where you have people coming in quite close to their last drink, where you would really want to make sure that you were observing for those initial signs and that you were talking to that person and asking when their last drink was. Once they're up on the unit, it's normally that kind of period has lapsed and you just want to be doing those assessments as ordered that will have already been initiated. But that's an excellent question. It is a bit nuanced. If you're ever unsure, the answer is always a little bit more work. I would just stick with the Q1H frequency in order to avoid missing anything. But yeah, that's a great question. Any other questions before I move on to the take-home naloxone? Okay. So the take-home naloxone kit program is province-wide. In the hospital, all our take-home naloxone kits are in the Omnicell, and so they get ordered on the MAR, and then we go and access them through the Omnicell. You can do this nurse-initiated activity course on Learning Hub, and it's not just about naloxone, it's about initiating a hypoglycemic protocol or an anaphylaxis protocol, or in this case, you can initiate your own order for a take-home naloxone kit. I mean, AMCT will always order it, but sometimes, maybe they got it and they used it or they lost it or whatever, and you want to have another one quickly, then you can just write your own order. So I encourage people to do that nurse-initiated activity on Learning Hub. And really, unless someone's certified, we just want to dispense that kit immediately. Yeah, this is not something we want to gatekeep in the community. They're readily available. And of course, I'm a broken record. There's a nursing practice standard about it. In the vial, in case you've never seen one, and if we were in person, we could do a whole demo, but in the absence of that, you just get a lot of gesticulating. So the kits themselves, you've definitely seen them clipped onto lots of people's backpacks or around. They're a little black case, and inside we've got 3 vials of 0.4 milligrams of naloxone. That's 1 ml each. There's a breathing, a one-way valve breathing mask. There's 3 Vanish Point syringes. There's gloves, and there's instructions. And so when we're handing out take-home naloxone, and I'm kind of always offering it up to people. Hey, do you want another kit? Do you want a kit for your friend? Do you want a, kit for your bag as well as your wheelchair? And then letting, often our patients have given way more Narcan than we're ever going to give. They reverse overdoses on each other. They take really good care of each other. We can learn a lot. Your patients could probably teach you a lot, but sometimes we do come across folks that maybe haven't had an overdose before, or their friends or family, and they want to be able to respond. So we're going to let people know, hey, do you know what naloxone is? So, it's a medication that's very safe to give, and that it's going to reverse the slowed or stopped breathing from opioids. It does not have any impact on benzodiazepines, GHB, alcohol, or any other medication. And so if somebody doesn't have opioids in their system, it's not going to do anything. And that's why it's very safe and not a controlled substance. Hopefully we'll see naloxone working in about 2 to 3, up to 5 minutes, where we see someone's, if they have a respiratory distress or their respirator rates are really low, that we see that coming back to a normal rate. Sometimes it does take multiple doses of Narcan in order to have that effect, particularly if they have some of the stronger fentanyl analogs. And again, it doesn't sort of disintegrate the opioids. It just bumps them off, and they still are floating around and can reattach to the opioid receptor once naloxone wears off. So they are still at risk for an overdose. as you can see, that 20 to 90 minute half-life of naloxone is an important piece, because even if that one initial overdose is reversed, once the naloxone wears off, the person can go back into an overdose. Just a bit of a diagram about, how Narcan works. It's very sticky to that opioid receptor, but it doesn't last for super long time. So we do want to make sure that we're still offering people like things that can keep them safe in that time. We see, a really big complicating factor of responding to overdose because we have an unregulated supply. So there's no way of, controlling what's in there. And we see a lot of polysubstance use where people who think that they're using stimulants, they're exclusively stimulant users. Maybe they use crack or crystal meth. If their substances are contaminated with fentanyl, usually, those overdoses are extreme because they don't have any opioid tolerance. So they usually go down. Those are usually code blue kind of overdoses that we see a lot on the fourth floor garden. We've also see the contamination of benzodiazepines. The last report I saw provincially was that over 40% of our street supply of opioids are contaminated with benzodiazepines. So those are put in there. They can really act as an adjunct and kind of increase the effects or mimic the effects. So you kind of really, whoever's profiting from making those substances can profit more. Also, benzodiazepines are legal, so it's a little bit easier to transport them. Again, more profitable. But it is very complicated because it really can exacerbate the sedation, making it difficult for people to protect their airway and compounding that overdose death risk. So here's our little kit. And we want to kind of initiate conversation with people. So you're talking with a patient or a friend of their friend or family, where you're kind of walking them through the steps of doing the take-home naloxone. So we're going to ask them like, hey, what do you think an overdose looks like? And definitely the classic would be like this person's laying there and they're not moving, but with stimulants on board, sometimes we still see that psychomotor movement, even though really we're looking for this slowed or stopped breathing, gasping, gargling, snoring sounds, and signs that they are not getting enough oxygen. So depending on people's skin tones, that can look different. So we really just want to look for any signs of respiratory distress. And the acronym, and this sticker is inside the kits that we always use, is SAVES ME. So the S being stimulate, so we want to be like, hey buddy, are you awake? Can you wake up for me? I'm worried about you. You look like maybe you're not breathing. And sometimes, I stop all the time on my bike rides to and from work, and thankfully, most of the time people were just snoozing and they can go back snoozing. And I just say, oh, sorry, man, I was just want to make sure you were okay. And so we always want to, work with the idea, as we do anytime in nursing, that we let people know what's going on. Hey, I'm just really worried about you. I'm going to touch your shoulder and see if I can wake you up. So they don't respond to verbal stimulation. Then we want to try for, either a trap squeeze or maybe squeeze in between their thumb and their index finger and let them know that we're trying to wake them up. So that person might be the only one responding. They might have to go get a kit. They might have to go to call 911. So we tell people about the recovery position, why that's the safest position to leave somebody in. And then reminding them to call 911. So that's the very first step that they want to do, is get the emergency health folks on their way in case, in case they're needed for an increased response, and letting them know, this information that's written down here. And, I think that's always the step that I often forget. I just assume that I'm there and I got it covered. And the peer that I work with, Karen, is always reminds me, call 911 first thing. The A in Save Me is airway. This is extremely important, and don't underestimate that this is an intervention. Helping people protect their airway is often enough of an intervention to keep them safe and keep them alive. So again, with the benzodiazepines, we see a huge loss in muscle tone, or sometimes people are curled up or stuck in positions that they're not able to protect their own airway. So making sure we get to people even just doing that type of jaw jaw thrust, making sure that their airway is patent. With a lot of the fentanyl analogs, we see like a chest wall rigidity that sometimes involves jaw clenching. So we really don't recommend, even if you suspect that something in someone's mouth, is to like use like the blunt, like the bottom end of one of the syringes or a pen or something to try to scoop something out, and don't stick your finger in their mouth. That little one-way valve mask is available if that person is not breathing. The recommendation is to give 2 breaths followed by 1 breath every 5 seconds. This will, if that person were to vomit, this, protects you from that. It can't prevent, other things like COVID transmission, but hopefully in that situation, this is an emergency response. So hopefully people feel comfortable to give 2 breaths and continue with 1 breath every 5 seconds. And then we're going to evaluate, like, did our interventions work? One intervention, stimulate, getting somebody to wake up and take some deep breaths. That's an intervention. Airway, getting somebody's airway patent. That's an intervention. Was it successful? Is this person breathing? No, we're still really worried about them. We still don't think that, we're still very concerned for that opioid overdose. We're going to give a muscular injection of the Narcan. So we have practice kits on most of the units where we have little glass, like those glass ampules, so they can practice cracking them open. They just have sterile water in them, and they can practice drawing them up with the Vanish Point syringe. And then we're showing them that they can give that injection. A lot of times we see it given in the deltoid, but it can be given on that thigh there, kind of in the glute muscle, really anywhere. We're going at that 90-degree angle. We don't have to get down to skin. We don't have to alcohol swab. We can go right through someone's jacket or pants. It's very important to note the time you give an injection. It's also very difficult. So hopefully you're not the only one, because your sense of time really gets skewed when you're in that kind of your own fight or flight response. Your adrenaline's going, and you really want to note what time, because we don't want to give so many doses too close together. So we really want to give that 2 to 5 minutes. Is this person, do I see any response? And again, we're not looking for people to wake up because of this huge contamination with benzodiazepines. We're looking for people to start breathing normally. Are their breaths getting a little bit deeper and more regular and more consistent? That's the response that we're looking for. If we don't see that response, then absolutely let's give another dose. And you can give all 3 doses in a kit. And I've even heard of, like, there's another kit available and you want to keep giving those doses, just making sure that we're spacing them apart. Hopefully this person's going to wake up a little bit, enough for you to say, oh my gosh, I was so worried about you. I really like to just go with the objective signs. I don't tell people you had an overdose. For people might really often don't remember using, they don't remember how they got there. It's very scary for them waking up. It's very disorienting, and they're in withdrawal because we've, bumped all those opioids off. So I just say to, oh my gosh, your breath, you weren't breathing, or you're breathing, this is what your breathing looked like. And you were, you really looked so unwell, and I was so worried about you. And I gave you a dose of Narcan. I'm so happy to see you sitting up. And we do want to encourage people to go with the emergency service providers when they arrive, because especially if we didn't see someone go down, we don't know if they, hit their head on the way down, or we don't know what else is compounding that situation. Very seldom do people want to go, and that's understandable. So then we would just want to say, just make, the Narcan's going to wear off, and I know you feel really, sick right now, but it is going to wear off and you are going to feel better. And just be careful if you're going to use again, make sure you're around some people, or go to an overdose prevention site, and just really want to convey our care for people and our understanding. On the technical side of things, when you've dispensed this kit, you actually, on the MAR, you would say it's not given, and then there's an option to say that you dispensed it. Whenever we give, any type of medication to go, which includes naloxone, you'll have this little sticker that goes on the kit. And then there's also this little ticky box thing that we report back toward the heart. And those are most often found on a clipboard next to the Omnicell, so that we can report back to them that we, handed out the kit and the information that they collect provincially. And that is the end of my take home naloxone train the trainer. Now you can dispense these kits. And also, if you would like to go and get a kit of your own, you can go to our overdose prevention site, and the staff there, you can say, you know, I just did the training in general orientation with Naomi. Could I get my own kit if you want to have one for your life? Or you can always go and get one from any pharmacy. Any questions about the take-home naloxone or anything else that I talked about before I go? You've got a couple minutes. Yeah, well, do I personally believe? Yes, I do. It's probably the quickest way to answer that. Yes, I do. I would love to talk to you more about it at length. I think that I can only say that as my personal, not representing PUC. So yes, so you're saying and correct me if I misunderstood your question. So when we have those Vantage Point syringes that we filled up with a dose of Narcan, they can absolutely go through clothing, you know, through pants, through someone's jacket. It's a pretty long needle. It's an IM injection. Yes, you can go through clothing. If I didn't understand your question, then please let me know. Any other questions? Yes, you can go to any pharmacy, and usually the word, you can say, I've been trained in how to use a take-home naloxone kit. And I am likely to witness someone who is at risk for an overdose. Those are sort of the key things that they have to check off. Most pharmacies will just hand you a kit. No questions asked. Yeah. Or like I said, you can go to the overdose prevention site here at St. Paul's. Is the IV preferred route for Narcan if the patient has an established IV access? I would say yes, that's going to be your quickest, have the quickest effect. But we still often would give it IM. That's probably even more frequent, but yeah. I think that is there a practice restriction for scope for between, yeah. LPNs can't administer it through a IV, so they would be giving it IM. Narcan's going to wear off. That means it's up to the patient. It's up to the patient if they want to follow up. It's not mandatory. We would recommend that they go. Like I said, very few people want to go follow up with the emergency department. Yeah. So that's when we would offer them other options or offer other suggestions of, is there someone that you can hang out with? Make sure that they have a Narcan kit with them. Obviously, if they're on the unit, then we're going to continue monitoring them. That's part of our job. But if this is out in the community, then just letting people know, hey, is there someone you could go? Can you go to one of the overdose prevention sites? Do you have someone that you can hang out with? Is there any kind of community resource? At least make sure you're around where other people are. Yeah. Cool. Very cool. Thank you. Thanks for your questions. I'm going to hand it over to my colleague now. Yeah. Sweet. It's on me. All right.
All right, to segue onto Naomi's presentation, you've been hearing a lot about the overdose. So we're now talking about overdose prevention site. And I have here with me Carleen Patterson. She's the nurse educator for our Wilbur Health.
Thank you. Hello, everyone. Yeah, I think this is a good segue into this topic. So we're going to talk about the overdose prevention site, or the OPS or OPS here at St. Paul's. So if anyone doesn't know what an overdose prevention site is, it's a place where people can inject their previously obtained substances under supervision of staff who are trained to respond in the event of an overdose. So clearly, the main goal of an OPS is to prevent death and reduce harms associated with injection drug use. So, we can prevent or reduce harms through education around safer injection practices and by providing sterile supplies. This also helps reduce transmission of bloodborne viruses, connects people to care and resources, really promotes a culture and environment of safety and trust. It's a place where people they have a clean space where they can prepare their substances and dispose of any supplies afterwards, including syringes. So, then people are less inclined to be hiding syringes on their person or at their bedside. They know that they have a place where they can easily access them and dispose of them. We do provide drug testing there, so fentanyl and benzo testing. During operational hours, we do think that we're seeing decreased substance use on the units, and we don't have data around this, but a big goal is reduction in patient-initiated discharges, and really just helping to support patients to be able to stay in hospital to complete their treatments. So why we decided to open an OPS inside St. Paul's. So this is not a common occurrence in other acute care settings. Unfortunately, when we opened in February 2021, we were the second acute care setting in Canada, I believe in North America, and I actually believe globally, but I can't say that with 100% certainty, that had a site like this inside. So the first one is a safe consumption site that's at the Royal Alec in Edmonton. So this was really exciting and sort of novel idea, but we knew that we needed this here. Prior to the site inside, there was a trailer overdose prevention site out in the parking lot here. It was a peer-led model and supported the community as well as patients. And they announced that they were going to be moving locations, and we knew that we needed somewhere still for our patients to access. When we didn't have the trailer before, patients were really left at all hours of the day, really left to use in unsafe areas of the hospital, or they would leave the hospital altogether to find a place to more privately and safely use their substances. And this really does align with our philosophy of care for patients and residents who use substances by providing a safe and harm-reducing environment. It also respects the autonomy and promotes compassionate and respectful care. So our site here looks very similar to this picture, only we just have 4 booths. It's a small location. It's located on the 4th floor in the Providence building, right sort of off of the cafeteria. It's right near the public bathrooms there. If you're walking by, feel free to, pop your head in. If the curtain is drawn, though, that means that there is a patient in there. So we would just ask you to respect the privacy and not pop in then. But if there's no patients in there, feel free to pop in, say hi to the staff there. As Naomi said, you could grab a Narcan kit. The staffing model is currently LPNs, and we have 2 staff on at all times for both their safety and patient safety. This does require that we close for breaks. So we're closed between 2 and 3 and then around 5:30 as well. Our current operational hours are 10 a.m. to 8 p.m. 7 days a week. And to close at 8, that means that the last visit for injection is actually 7:15. So if you're sending patients down, it's kind of important to know that. It's frustrating for people if they arrive at like 7:45 and we're actually closing up and only providing supplies and drug testing at that time. We are actively looking at changing certain key elements of the site, so including more peer support in the model of care and expanding hours. The site is only for patients of the hospital, but that can be anyone who's really accessing the hospital for medical purposes. So if someone's going to the emergency department, someone's going to the outpatient antibiotic program, OPAT, if they're coming in for any diagnostic tests, or if they're an inpatient. We see people from the RAC, from JRC, from other outpatient clinics. We also will support a family member or like a friend to come with a patient as well. The services that we can offer are harm reduction education and supplies, and this would include supplies for IV line use, which we do see a lot here. Being a acute care setting, a lot of people have IV lines. We offer drug testing, as I said, of course, overdose response, take-home naloxone kits, and training. You'll see there, unfortunately, we don't have an inhalation space, which is a big problem here. It's a big problem provincially that there's a lack of supervised inhalation areas, but we're seeing that here at the hospital as well. So we do provide safer inhalation supplies, and we can suggest testing drugs. We can give a Narcan kit, but unfortunately we don't have an area at the moment, which is again something that we are really actively working on. And I feel like I've been saying that for a long time, but it feels like we're maybe actually getting some momentum here. So things for you to know if you are working on a unit here at the hospital. Patients can access the site freely during operational hours. There's no need to like call down and let us know. Likewise, we will not be calling up if a patient shows up. The only reason that we would call over to the unit is if we have to give some sort of verbal handover for overdose response or any other sort of medical emergency or major safety event. But otherwise, we will not be providing a handover, and we will not be charting in Cerner. So Cerner, we do chart overdose responses. If a patient does have an overdose at the OPS, the staff there will do everything they can to safely transport the patient back up to their primary unit. However, because as I mentioned, we have to have the two staff at all times, if there's a situation where there's other patients at the site and there's no one like myself or Naomi or no one sort of extra that can help transport a patient back, they may call the unit to help with that. We really avoid that at all costs because we know that the acute care units, you have an assignment and you're busy, but there is the odd time that could happen. If there's a severe overdose that is not responding to naloxone or any other medical emergency, the staff at the OPS will call for a code blue. And so if someone did experience an overdose down at the OPS and the staff were to bring them back up to the unit, they would chart in Cerner, but also give a verbal handover. And then once you've received that handover, the MRN on the unit is responsible for ongoing monitoring. So I know Naomi was talking about naloxone wearing off. So we know that it will start to wear off 20 to 90 minutes. So even if someone isn't using any other substances, the overdose can return. So they need that ongoing monitoring. And you may decide based on your own assessments that the patient requires additional doses of naloxone. So this can be given as a nurse independent activity. It can also, most patients who are accessing the OPS would be followed by AMCT, or all of them should be followed by AMCT and have PRNs and naloxone available. Once back on the unit, it's also MRN's responsibility to notify the MRP. So the OPS will not be notifying the MRP unless it's a code situation, then the code team or OPS will call. But otherwise, if you can let the MRP know, and also let AMCT know during sort of regular hours, 8 a.m. to 5 p.m., because they may want to adjust dosing or see if there's anything else that they can offer the patient or anything that's missing in their treatment regime. And then CCOT's also a great resource for the units if your patient is unstable in the unit post overdose or you have concerns around their level of consciousness or their rest rate. This monitoring is actually taken directly from the overdose management document on SHOP. So it's this document here, which goes over the second page of this document actually has a decision support tool to help you navigate and sort of make decisions around if naloxone should be administered and the dosing. And then it also goes over monitoring afterwards. So again, this is found directly in that SHOP document, which I do recommend taking a look at. This is that decision support tool that I was saying. So, I mean, I think it's something that's great to be somewhat familiar with and good to just, you know, have readily avail for yourself if your patient is at risk of an overdose. And the notification, as I mentioned, we need to let AMCT know as well as the MRN. This practice pointer is created just sort of kind of like summarize this information around what you need to know for the unit and what to do if your patient comes back up to the unit after an overdose and sort of ongoing monitoring. So this is found on PHC Connect, and I know a bunch of the units have these posted as well. And that is all. Happy to answer any questions you have about the OPS. My contact info is also there if something comes up later. Happy to chat over email or connect individually. Okay, I'll see if there's any questions here. Have to encounter code blue. Oh, yeah, good question. So since we've opened, so we've been open almost 2 years. It'll be 2 years in February. We've called 12 code blues to the OPS. I'll explain that a little bit more after. We haven't actually had to call a code blue, knock on wood, inside the OPS in about a year. So our initial sort of algorithm for calling codes, we would call a code blue quicker. And now we allow a little bit more time in the nurses to administer a bit more naloxone before calling, of course, within their clinical discretion. However, there are a lot of code blues out on the 4th floor garden because, as I mentioned, we don't have an inhalation space. So the OPS staff will often get notified if someone's in distress outside. Usually it's by another patient, sometimes a staff member. And so they will often either call a code blue or call for urgent security to go check on someone. Or they'll go check on them themselves if they can, if they don't have other patients inside the site that need support. Yeah, so currently, no, there's no inhalation space, but that is something we are really actively working on. And I'm very hopeful that will be up and running soon. Stay tuned for information on inhalation sites. Yes, if a family member wants to come with a patient, that's always fine. If there's a family member who wants to access this service and they're not with the patient, so if the patient doesn't use substances or if they're not able to come down and the family member wants to come, they definitely can. I would maybe suggest if they've never been to the OPS before or if they're not coming down with the patient, it could be good to just call down to the OPS and let them know. Because if they're not familiar and the person doesn't know, maybe to say like, oh, I'm here visiting my family member and they just arrive and they're not connected to the hospital, the staff may suggest that they access a community site, and I would never want there to be that sort of confusion. So either direct the family to let them know, be very clear that you're visiting your family member here at the hospital, or you as the nurse or other staff member could give the OPS a call down to let them know. Oh, yeah, good question. Yeah, I think there's no issue if someone is using intranasally, they could do that at the OPS. I don't think it's something that we've seen, but would have no issues with that. The only limitation is inhalation, just because of staff exposure in an indoor space. Yeah, but good question. So many good questions. Wow. All right. Okay. Thank you so much.
Thank you, Carlene. Let's have a 5-minute stretch break while we prepare for the next presentation. Thank you. Welcome back, everybody. Let's move on to our next topic, which is cardiac arrest, code blue. And here with me is Andrea Fong. She's the nurse educator for 5A, our cardiology unit.
Thanks very much, Carrie Ann. Good morning, everybody. So as Carrie Ann said, my name is Andrea, and I am the nurse educator for 5A at St. Paul's, which is the cardiac medicine unit. And I'll be talking to you today about cardiac arrest, or code blue. So at St. Paul's, we are fortunate to have a critical care outreach team, or CCOT as they're known. CCOT is an interdisciplinary team that consists of an ICU nurse, ICU physician, and a respiratory therapist. And they provide 24/7 service here at St. Paul's. And what is great about CCOT is they bring critical care knowledge, skills, and expertise to patients throughout St. Paul's who are at risk for or who are actively deteriorating. And they work collaboratively with the primary care team to provide patient care. Research has shown that 70 to 84% of patients who have an in-hospital arrest have documented signs of clinical deterioration 8 to 24 hours before the event. So keeping that in mind, the premise behind CCOT is early identification and management of these patients who are deteriorating or who are at risk for deteriorating before they reach the point where we would have to call a code blue. So for example, you should call a CCOT for any patients that are exhibiting a threatened airway, if their oxygen saturations are less than 90%, or if they have increasing oxygen requirements. For patients who have a respiratory rate that's less than 10 or more than 30 breaths per minute, if their systolic blood pressure is less than 90 or greater than 210, if their heart rate's below 40 or above 140 beats per minute, if there's a sudden change in the patient's level of consciousness or a decrease in their level of consciousness, if the urine output is less than 100 milliliters over the past 4 hours, if they have an elevated national early warning score or NEWS score, and in general for any patient that you're worried about. This would all be criteria that would warrant calling CCOT. However, you would want to take your patient's baseline vital signs into consideration before making that call. So for example, on 5A, we have heart failure patients who are prescribed medications to lower their blood pressure. And it's not uncommon for a heart failure patient to have a systolic blood pressure between 85 to 95 and be asymptomatic. So if I were to check the patient's blood pressure in hospital and get a systolic reading of 85, I wouldn't necessarily call CCOT, especially if the patient was asymptomatic and if the blood pressure reading was within the patient's baseline. So again, these are all kind of guidelines that are not hard and fast rules on when to call CCOT. But before contacting CCOT, you want to make sure that you notify the physician so they are aware of the patient's condition and that you are concerned enough about the patient that you are going to be contacting CCOT. As direct care providers, you guys are key to identifying these patients as early as possible, and you should never hesitate to call CCOT if you are concerned about a patient. The phone number for CCOT is posted in all the nursing stations throughout St. Paul's, so it is readily accessible, and CCOT is definitely a resource available to you here at St. Paul's. So all that being said, there are different situations that would warrant calling a code blue, and that leads us into some of our Slido questions. So the first question being, for what reason would you call a code blue? Yeah, absolutely. Cardiac arrest, respiratory arrest. If there's no pulse, absolutely. Yeah, if the patient's unresponsive, they're not breathing. Yeah. Yeah, these are definitely all good reasons to call a code blue. Some other situations that would warrant calling a code blue, if your patient was having a seizure, perhaps they're actively hemorrhaging, so maybe they're having a big GI bleed. That would be a good reason to call a code blue. If they have a severe hypoglycemic reaction, which lead probably to unresponsiveness, that would be a good reason to call a code blue. If they're desaturating rapidly, or maybe they had an airway obstruction that they couldn't clear, those are all reasons that you would call a code blue. As well, if your patient was still responsive, but they had rapidly deteriorating vital signs, and you wanted to get the arrest team to the bedside quickly, code team for sure to have more help. And then, yeah, in general, if you wanted to have, if you needed more support for a patient with a declining health status, you could definitely call Code Blue in that situation. Okay, perfect. Next question. So this is more of a case study. So Dorothy, she's a 58-year-old female. She's admitted with a chronic right foot ulcer for a possible ulcer debridement, and also for a possible right foot amputation. She's got allergies to aspirin, fish, and dairy. She's got a previous medical history that includes insulin-dependent diabetes. She has a history of an opioid addiction, for which she's on methadone, bipolar disorder, neuropathic pain, and she's had a traumatic injury to her lower back. So Dorothy has an arrest in hospital. What do you guys think are some potential causes for arrest for her? Yeah, absolutely, hypoglycemia. She is insulin-dependent diabetic. And on the flip side of that, we don't know what her glycemic control is like. So perhaps she has high blood sugars and she's got DKA or a diabetic ketoacidosis. Yeah, respiratory depression, and that could be related to medications. Yeah, sepsis would be a huge one, potentially. We don't know what that right foot ulcer looks like, but I mean, she's being admitted to hospital. They're talking about debriding it, possibly about amputation, so we know it can't be good. So having an open wound like that, definitely she's got a higher risk of sepsis. And anaphylaxis, yeah, again, we don't know what her allergies, like we know she's got allergies to aspirin, fish, and dairy, but we don't know how severe they are, but that's always a concern. Anybody else? Anything else? Maybe. Perhaps she had a fall. Perhaps it's just like a progression from her traumatic injury to her low back that she's had, that she could have an arrest due to a spinal cord injury. So in regards to the respiratory depression, we know that she's got an opioid addiction. So perhaps maybe she's gone off unit and she's used something. Perhaps if she's been prescribed something like methadone for her addiction, perhaps we're in like an overdose situation, which someone just put in as the answer. So that's all great. Perfect. Thank you very much. Next question.
You have a child?
How do you call a code blue? Mm-hmm. Sorry. So what are the different ways you can call a code blue? Yeah, code blue button, 7111, perfect. So yeah, most definitely. So at the head of the bed, mounted on the wall of every patient bed, there is a code blue button. I think, Karen, do you have an example of it? Karen has an example of it. It does have a little plastic cover on it, so you'd have to flip that up in order to press the button. And when you do press the button, it notifies the arrest team as well as switchboard, so they will make an overhead announcement for that. The other way would be to pick up any of the hospital phones and dial 7111 and speak to the switchboard operator. And then you'd have to tell them what kind of code you would want to be calling. So in this instance, it would be a code blue. You need to tell them the location of the code blue, so the site and the ward. So St. Paul's Hospital 5A, for example. Who's calling the code? So you give them your name and then your local. Then you want to remain on the phone until the overhead announcement is made just to verify that it's accurate. But yes, 7111 and the code blue button. Perfect. Next question. This is the child one. So if you have a visitor who is a child who has an arrest, how would you call a code blue in this instance? Yeah, so code pink would be for a neonate or a baby, absolutely. So someone, if it was a child who's just a little bit older, how would you call a code blue? Yeah, so in this instance, you wouldn't use the code blue button. Someone did put, call the same way, but say it is a child. So yes, in that way, you would pick up the phone, dial 7111, and then when you talk to the switchboard operator, you'd want to tell them that you want to call. Sorry, just wait for this announcement.
Code red, Gerard level 2, Route 2 Charlie 205. Code red, Gerard level 2, Route 2 Charlie 205. Code red, Gerard level 2, Route 2 Charlie 205.
Sorry about that. So you'd want to pick up the phone, dial 7111, and then when the switchboard operator answers, you want to tell them that you want to call a code blue pediatric. Okay, and this is important to ensure that the code blue team is made aware so that they can bring the appropriately sized resuscitation equipment to the arrest scene. Because we're not, St. Paul's and Mount St. Joseph are not a pediatric hospital, they don't have that equipment so readily available, so you'd have to go and get it special. So you definitely want to make sure that you call the code blue as a code blue pediatric. So dial 7111. And you wouldn't be able to notify them about this if you were to press the code blue button that's mounted on the wall. So that 7111 is the best way. Okay. And then last question. And would you call a patient, would you call a code blue on a patient who is a DNAR? I like how in live time it just changes. It's cool.
Amazing, because it's yes.
Yeah.
So nice to see.
So I got 50% say maybe, it depends. And then it's kind of 25% between yes and no. Okay, more for the maybe it depends. Well, that maybe it depends is in the lead. Okay, so the maybe it depends, they have it looks like. So we do have different levels for DNAR statuses. So, anything from a DNAR 5, which is no CPR, but referral to critical care and okay with intubation, all the way to DNAR 1, which is no CPR, supportive care, no intubation, more as a palliative care. So in that instance, the DNAR 1, you would not necessarily call a code blue, but for DNAR 5, you would. As if the patient was having a respiratory arrest and they potentially needed intubation, you could call a code blue and they could come and intubate because the patient would be okay with that. And as well, even if they were still responsive, but they were deteriorating, to call a code blue, you could help facilitate a quicker transfer to critical care, which in a DNAR 5, the patient would be okay with. So really it depends. It depends on what DNAR status they are, what level they are. And also something to be aware of, there may be some special instructions in the patient's DNR order. Some patients are okay with defibrillation. Some patients are okay with BiPAP, but maybe not intubation. And some may just not want CPR. So there might be some caveats to those orders. So just something to be aware of. So if a patient was okay with defibrillation and BiPAP, you would still call a code blue because both of those skills would require a transfer to critical care for, or having the critical care team at the bedside if it was defibrillation in that instance. Okay, great. Thank you very much. Go back to slides. Oops. This one. Okay. Okay. So in terms of code blues, there are some site-specific differences between St. Paul's and Mount St. Joseph. So at St. Paul's, the code team is responsible for bringing the cardiac arrest cart to the code scene. They ask us not to bring the arrest cart to the bedside with the exception of 5A and 5B, where the nursing staff are trained in early defibrillation. Okay, and early defibrillation would require use of the Zoll, which is mounted on the arrest cart. So that's why we bring the arrest cart to the scene. In terms of the makeup of the code blue team, at St. Paul's, it's comprised of the ICU physicians, which include the attending fellows, residents, clinical associates, possibly an anesthesiologist, respiratory therapy, 2 ICU nurses, a member from the IV therapy team, as well as security. And if the code blue were to be called on 5A or 5B, you may see the cardiovascular surgeon as well. Social work, spiritual health practitioner, clinical resource nurse, and the clinical coordinator may also attend the Code Blues. At Mount St. Joseph, they ask that the ward nurses bring the arrest cart to the scene, and the code team at Mount St. Joseph is comprised of the emergency department physician or the clinical associate / night physician if it's on a night shift, respiratory therapy, 2 ACLS trained nurses. So on a day shift, that would be 1 nurse from the emerge department and 1 nurse from HAU. And on night shift, that would be 2 nurses from HAU. Clinical resource nurse, clinical coordinator, and security would also attend the code. Spiritual health, social work, you may see them as well. And then of note, during the day shift, if you have an emergency department nurse with the arrest team, that nurse usually attends to the patient while the HAU nurse charts and the ward nurses help with CPR. And the assistance of the ward nurses for CPR, that's true for both sites, St. Paul's and Mount St. Joseph. Okay. So as well, the Code Blue alarm bells also sound different between St. Paul's and Mount St. Joseph. So I'll play you the different Code Blue alarm sounds now. Click it. Oh, here. So this is St. Paul's.
Hey there, all you nurses. Stop what you're doing and gather around because it's time once again to play What's That Sound? What's That Sound? What's That Sound? First up on today's program is sound number 1, better known as the patient call bell. Let's have a listen, shall we? Once again, that was the patient call bell. Next up in our noise spectacular is sound number 2, more commonly referred to as the staff alert button. Oh yes, the famous staff alert button. Gotta have it. And finally, rounding out today's lineup is sound number 3. Yes, everyone's favorite, the cardiac arrest button. The infamous cardiac arrest button. Almost makes your heart skip a beat, doesn't it? Well, that about does it for this week. But before we go, let's test your memory with the audio daily double. Please identify the following sound. If you said the cardiac arrest button, you are absolutely right. If not, please rewind this tape and try again until you do get it right. This is Dr. Kent Heria saying so long for now, and don't forget to join us again next time for another exciting episode of What's That Sound? What's That Sound? What's That Sound?
Okay. And then, yeah, yep. This one. Okay, and that was the Mount St. Joseph Code Blue bell, if you're wondering what that one came out of nowhere from. Okay, so we'll go back to the slides. Good. So at St. Paul's, we recently got some new defibrillator pads that provide feedback about how effective the CPR we are providing is. So this oval shaped puck here, I don't know if you can see it, is detachable from the defibrillator pads. And then what happens is you put that oval puck on the patient's chest under the hands of the person that's providing the CPR. And it gives information about the depth and rate of compressions, as well as the recoil. And this information is displayed on the Zoll's monitor. So on here, sorry. So this is the puck. I think I used the laser pointer on the wrong screen. So that's the puck that's detachable from the defibrillator pads. And this is an example of what the Zoll screen shows. So it gives you information about the depth, the rate, how good recoil is, and overall what your CPR quality is like. And in this example on the right side here, it's better quality CPR because the rate is better and the release or the recoil is better. So the little diamond that indicates the CPR quality is full. So the Zoll is telling us that it's better. So on the topic of CPR, I do have a couple more questions for Slido. So how deep should your compressions be for CPR? Yeah, 2 inches, 5 centimeters, absolutely. It could be that you go deep enough and hard enough that you break the ribs, unfortunately, yeah. But yes, so at least 2 inches or 5 to 6 centimeters. And if you're more of a visual person, it's like the short end of, or the short side of a credit card, okay? And next question. How fast should your compressions be? Yeah, 100 to 120, perfect. Yeah, so that sweet spot's between 100 and 120 compressions per minute for sure. Great, thank you. Okay, so just as a quick review, so for CPR, you want to push hard and fast. So compression should be at a rate of 100 to 120 beats per minute. And at a depth of 2 inches or 5 to 6 centimeters. Nobody mentioned the song Staying Alive, but for the longest time, that song has been used to kind of keep time for CPR compressions. And for CPR, you want to make sure that you want the chest to have full recoil, meaning that you want the chest to come all the way back up in between compressions, okay? Because during that time, that's when the heart passively fills, so that when you actually go to do the next compression, you have something to push out, okay? And lastly, you want as little time off the chest as possible. So meaning that you want to limit the amount of time that you're not doing CPR, okay? So those are all the big key things for CPR. So if any of you have been in a code blue situation before, you know it can be very chaotic. There are a lot of steps that happen all at the same time in an actual emergency, but it is important to have a basic understanding of the procedure. So if you find a patient unresponsive and not breathing, you want to call for help. You want to call the code blue. So you're either going to press the code blue button that's on the wall, or you're going to pick up the phone and dial 7111. You're going to want to don appropriate PPE, which I'll talk about in the next slide. You want to stay with the patient and do your best to stay calm. You want to lower the head of the bed so that it's flat. If they have pillows, if the patient is close behind their head and neck, you want to take those out, okay? And if the patient's on the floor, you want to ease the patient onto in a chair in a seated position, you want to ease that patient onto the floor. Assess the circulation, airway, and breathing. And if there's no pulse, you want to immediately begin chest compressions. You also want to place oxygen via simple face mask at 10 liters on the patient. And hopefully someone's brought you the arrest board and the ambu bag, okay, if you have one on the unit. If CPR has already started and the arrest is being run in the bed, you want to place that arrest board underneath the patient. You want to ensure a clear access route to the patient. Bring in the WOW or MDC to the bedside so that the arrest team can access the patient's chart. And then when the code team arrives, you want to make sure that you give them a detailed report on the patient. And then at the end, when everything is said and done, it's always a good idea to debrief with your team after the code. Talk about what went well during the arrest, what didn't go so well. For some of your colleagues, it could very well be the first time that they've been a part of an arrest situation, and that can bring up a lot of emotions. So always good to just sit down as a group and just have a talk about it. So in terms of PPE, so green patients, so meaning those patients that are not suspected as having COVID because they have had a negative swab and also don't have any symptoms of COVID, you would only need to don a surgical mask, eye protection, so meaning goggles, a visor. Some of the surgical masks actually have a face shield on them that you could use, and as well as gloves. But for yellow or red patients, meaning patients that are under investigation for or have confirmed COVID, you want to don airborne droplet and contact PPE, which includes your N95 mask, eye protection, so again, goggles, a visor or face shield, and then gown and gloves. So now I'm going to play a video that reviews CPR. It goes over the different responder roles. It's a bit outdated, but the concepts are still applicable. If I can find it here.
Into professional education videos and tutorials. Code Blue, What to Do, a CPR review. We feel it's important to review the steps of initiating CPR rather frequently so that you have the confidence to perform CPR in an emergent situation as needed in a hospital setting. A cardiac arrest that occurs within the hospital setting is much different than a cardiac arrest at home or out in the field. At PHC, we know that help is close by and we would never be alone for long in a Code Blue situation. We have designated roles for the first 3 persons on the scene. First responder. First responder is the person who discovers a patient who appears to be unresponsive. What you do in these first 3 minutes could save this person's life. If you are the first responder, your job is to assess whether the patient will respond. Do this by tapping on the patient and loudly calling their name. If there is no response, ensure they're lying on their back and on a flat surface. If they're lying face down, carefully roll them onto their back. If you need to lower the bed, most have a quick release CPR lever to lower the bed in a hurry, typically located below the mattress at the head of the bed. If safe to do so, open the airway by tilting the head and lifting the chin gently. If there is a suspected spinal injury, then use the jaw thrust method. Using 3 fingers, feel for the carotid pulse. If there is no pulse, immediately call for help. Either press the Code Blue cardiac arrest button or shout out for help. Before starting compressions, quickly remove clothing that will get in the way of pushing on the chest. Then landmark the correct hand position using your hand that is closest to the patient's head. Place it into the patient's axilla furthest from you and slide your hand back towards you to the center of the chest. The heel of your hand should now be centered on the sternum. Start compressions. Place one hand on the top of the other, intertwine and lift the fingers, lock your elbows, and align your body so you are perpendicular to your patient. Press down with your shoulders approximately 5 centimeters, 2 inches, and then release the pressure on the chest to let it come back to normal position. You need to push on the chest hard and fast at a rate of 100 times per minute. Similarly to the beat of the hit song by the Bee Gees, Staying Alive. Second responder. The second responder to arrive on the scene is responsible for assessing the airway and breathing. They bring the arrest board and bag valve mask found in the nursing station. Ensure you know the exact location on your unit. If the patient is on a soft surface, such as a bed, place the arrest board under the patient's back. There is no need for the board if the patient is on the floor or on a hard surface. If the patient is not breathing and no foreign bodies are detected to be obstructing the airway, tilt the head and lift the chin to keep the airway open. Using one hand, position the bag valve mask over the nose and mouth and attach to the oxygen outlet. Ensure that the flow of oxygen is on and that you have an adequate seal around the mask. When the chest returns to the normal position between compressions, gently squeeze the bag using the other hand to deliver the ventilation. Ventilation should occur once every 5 seconds, delivering 10 to 12 breaths per minute. Do not stop compressions to deliver the ventilation if possible. 2 persons may be required in order to secure the mask and effectively deliver the ventilation. While the first responder continues with compressions, the second responder maintains a seal around the mask, and the third responder squeezes the bag in coordination with the compressions. Continue doing this until being officially relieved by an RRT. Third responder. The third responder is to quickly assess the physical area and ensure a clear roadway to the patient. They move or remove any chairs, trays, commodes, and any excess clutter from the room to make way for the Code Blue team. They also get the glucometer, chart, MAR, and a footstool for the CPR operator, then check to make sure that oxygen and suction are working properly and assist with ventilations. Subsequent responders. Subsequent responders will need to be directed by the first responder. Responsibilities may be to provide relief for the first responder and switch out every 1 to 2 minutes. If not already done, get the chart, MAR, and print off the most recent blood work results. Prime 1 or 2 new IV lines with 1,000 cc's of normal saline. Tend to the other patients in these responders' assignments, contact the MRP, and or comfort the family members. Be ready to act as a runner to get the equipment or enter lab work into SEM. Continue with CPR until you're directed by the leader of the Code Blue team that they are ready to take over. Good work. Thank you for taking the time to do the CPR review with Providence Healthcare.
Okay, so as I said, the video is a bit outdated, but concepts are all still there. So as you saw in that video, there are some different roles and responsibilities for the different responders. So what I'm going to do now is go over a bit more detail, the different responsibilities of each responder. So the first responder, they activate the Code Blue. So they're either pressing the Code Blue button or they're calling 7111. Staying with the patient. Again, if the patient's in the bed, you want to lower the head of the bed till it's flat. Remove any pillows that may be behind the patient's head. And if the patient's in a seated position, you want to lower them to the floor. And this may require waiting for help to arrive in order to do that, because the body mechanics are not going to be ideal in that situation. You want to assess for circulation, airway, and breathing. If there's no pulse present, you want to start compressions. And as a first responder, whether you're the person who happened to come upon the patient or if you are the primary nurse, you need to stay at the arrest scene until the Code Blue team arrives, and you need to give them a report. Okay, you want to give them as much information about the patient as possible. For the second responder, they're going to bring the arrest board and the ambu bag to the arrest scene. If there's no pulse and CPR is already underway, if it's being done while the patient's in bed, you want to place that arrest board under the patient beneath their torso. Okay, and the purpose of the arrest board is to provide a firm surface on which the patient can lie during chest compressions. Second responder is also going to help maintain the patient's airway. So jaw thrust method or head tilt chin lift method. Okay, and you're going to be putting oxygen at 10 liters via simple face mask on the patient. And when the respiratory therapist arrives, they're going to take over managing the airway. They're probably going to be providing assisted ventilation using that ambu bag that you brought in. I know during the video that it showed that it said that the second responder should apply the bag valve mask or the ambu bag and start ventilating the patient, but really that should only be done if you have received specialized training and if you are proficient in using the ambu bag. Okay. Otherwise, you can just default and use the simple face mask with oxygen running at 10 liters and putting that on the patient. So third responder or responders ensure that there's a clear path to the patient. Hopefully someone's gone to get the stool for CPR. Someone's gone to go and grab the blood sugar, the glucometer to check for blood sugar and have primed the IV line with a liter of normal saline. You want to ensure that you bring the WOW or the MDC to the bedside, again, so that the arrest team has access to the patient's chart. You want to call the attending physician if they're not already been notified that their patient has arrested. And you need to support the other patients that are in the room and on the unit. Okay, you want to make sure that they're all safe as well. And then as a third responder, also just helping to manage the patient's airway, notifying family, calling spiritual health practitioner or social work to support family members if they were present when the code was started. And you want to ensure that you're available, and probably this is the most important thing, to be available to switch out as a CPR operator. Okay. Good quality CPR is very fatiguing, it's very tiring, and a lot of people can't even go the full 2 minutes. So you want to make sure that you're available in order to switch out as a CPR operator. In terms of a respiratory arrest, you want to apply oxygen via simple face mask at 10 liters. Okay. If you're trained and proficient in use of the ambu bag, you would want to don airborne droplet and contact PPE. Okay. And you want to place the mask of the ambu bag over the patient's face with the pointed area at the patient's nose. You want to make sure that you apply adequate pressure just to make sure that you have a good seal around the patient's mouth and nose just to prevent any air leakage. And then you want to provide 10 to 12 breaths per minute. So that's about 1 breath every 5 to 6 seconds. And if the chest does not rise, you want to make sure that you reposition that airway and try again. So again, if you're trained and proficient in the use of the ambu bag in a respiratory arrest situation, you can go ahead and do that. So this is a simplified diagram of the ideal positioning for starting a code. You can see your primary nurse is at the bedside, potentially has already started CPR. Okay, your secondary responder is at the head of the bed to help maintain airway, and they're applying that face mask at 10 liters on the patient. When respiratory therapy comes, they'll be at the head of the bed as well, and they'll take over management of the airway. Okay, your third responder is at the bedside as well. It looks like they're ready to step in and do CPR if needed. But as well, don't forget, hopefully someone's gone to grab the glucometer so they can check a blood sugar, gone to get the stool for CPR, priming lines for IVs, those kinds of things for your third responder. And then your most responsible nurse is at the arrest scene there, free and waiting for the arrest team to arrive in order to give them report. And again, if the primary person who found the patient is also the most responsible nurse, you want to relieve that person from doing CPR so that they are able to give report. Okay, so this is a diagram of the ideal positioning for running a code. So you see here, this is your code team leader. So that's your physician from the arrest team. And they're at the foot of the bed so that they have a good view of everything that's going on in front of them. At the head of the bed, you have the respiratory therapist, as well as potentially an airway physician. So maintaining the airway, potentially getting ready to intubate the patient. You have an IV access physician or IV therapy team member at the bedside, getting you IV access if you need it. Your primary ICU nurse is at the bedside, and they're responsible for administering the medications and working the Zoll. Your secondary ICU nurse is there, and they're the ones that are preparing the medications, timing CPR, and doing all the documentation during the code. And of note, during a code blue, the charting is done on paper, not electronic in Cerner, okay? You have your ward staff here. They look like they're all lined up and ready to provide CPR if needed. And then you have your primary nurse, most responsible nurse there at the bedside to give report to the arrest team. So there is an acronym that is helpful when giving report to the RS team, and that's SAMPLE. So any signs and symptoms prior to the code blue, patient allergies, medications that they may be on, past medical history, including their diagnosis, any lab results and blood sugar results, particularly ones that are outside of the normal range. So if the blood sugar was very low when you checked it before the code team arrived, you want to let them know about that, as well as maybe they had a really low or really high potassium. All good things that you need to let the RS team know about. And then if there was any events leading up to the code, any vital signs that you have, any procedures that they may have gone to and have recently just come back from, any equipment that they may have in their person. So for example, if they have a pacemaker, or perhaps they had cardiac surgery and they have pacing wires, as well, perhaps they're on 5A and they've had a ventricular assist device implanted. These are all the things that you would need to let the code blue team know about. So that's all the information that I have. Does anyone have any questions? Oops. Let's see. Let's see. Oh, okay. So the doctors are the ones that would fill out the DNR orders. So I believe that there's areas in there for the physicians to add notes or comments that so you would have to go to the order section to have a look, or perhaps it would be in the communication orders if there's something special that the patient wants in terms of their DNR order. Hope that answers the question. Anything else? No? Great. Thank you very much, everybody. Welcome to Providence Healthcare, and have a good holidays. Happy holidays.
Thank you, everybody. For our allied health colleagues, thank you for joining general orientation. For the nurses, we're going to have a lunch break, and I'll see the nurses at 1:15. Yep, 1:15 in the afternoon. So have a good lunch